Well, good morning. Welcome, everybody. We are expecting the secretary and the board chair to join us a little later this morning. And so in the interim, I'm going to call the meeting to order. So let's do roll call. Is this mic working?
Good morning. We don't have mics in the room, so I'm going to project from back here. I will start with roll call. Dr. Sandra Hernandez. Secretary Kim Johnson. Richard Cronick. Here. Ian Lewis.
Present.
Elizabeth Mitchell. Dr. Richard Pan.
Present.
Don Moltz. We have 4 present, 3 absent, and I know we are expecting the secretary shortly.
Sure. We have a quorum, so I'd like to now give it over to Director Landsberg to do executive updates. Please.
Thank you very much. Good morning, everyone. Welcome to our July meeting, and I'm going to start with the agenda. So of note on today's agenda, we have a vote to appoint the advisory committee members, though we will wait for that vote until Secretary Johnson is here. And again, want to appreciate Dr. Pan and Elizabeth Mitchell for working on that subcommittee. We have 4 informational items today. We'll return to the topic of the behavioral health spending definition and measurement methodology. We will be talking a little at a high level about HR 1, the federal budget reconciliation, and some of the changes we expect to see in California. And then we'll turn to the important topic of enforcement. So we'll be talking both about enforcement for those entities that are required to submit data and fail to do so timely. And we'll also begin a discussion about spending target enforcement and timeline. And I just wanted to make a note about the discussion about HR 1, the federal reconciliation bill. We will not be going into detail on the provisions of the bill, but we do want to acknowledge the widespread and destructive impacts of this federal bill. We know that millions of Californians are likely to lose health coverage. We know that there will be significant reductions in federal Medicaid and marketplace funding. The California Health and Human Services Agency released a webinar yesterday describing the provisions in detail and the impacts in California, including monetary projections about the billions of dollars that California will lose and the millions of Californians that will lose health coverage. So that was a webinar presentation by Secretary Johnson and the directors of the Department of Healthcare Services, covered California, and the Department of Social Services, Michelle Boss, Jessica Altman, and Jennifer Troya. So we do commend that to you for the more detailed analysis. In terms of my executive updates, I'd like to start by acknowledging that we're celebrating the 35th anniversary of the Americans with Disabilities Act, which was signed into law in 1990. And actually, that's where Secretary Johnson is right now, is at a commemoration of the 35th anniversary of the ADA, our nation's strongest measure to protect the civil rights of people with disabilities, to prohibit discrimination based on disability, and more importantly, and really broke new ground to require reasonable accommodations to provide meaningful access to everyone regardless of ability. So with so much uncertainty in today's world and rights of many kinds under threat, it's good to pause to celebrate this important piece of legislation and the impact it has had while we continue to work toward a more accessible future. I have a few HCI department program updates today. The recently enacted budget health trailer bill includes a new requirement for pharmacy benefit managers to both be licensed by the Department of Managed Healthcare and to submit data to our healthcare payments data program here at HCI. That data will include information about discounts, rebates, fees, and other payments, including payments made to PBM-owned pharmacies. So the administration is doing as much as we can as a state to look at how to rein in pharmacy costs, and we think this transparency component around PBM data is really a critical first step to have that transparency. So we've published a fact sheet on our HPD program page that describes the implementation of the PBM data piece. So we'll be engaging with the PBMs, and we'll be seating a PBM representative on the HPD advisory committee, which actually meets Thursday of this week. We are excited to announce that we have 2 new programs moving over to HCI from the California Health and Human Services Agency. So the Data Exchange Framework and the Office of the Patient Advocate, which are currently housed at Cal HHS, will be moving to HCI starting on August 1st. So we're excited to welcome the new team members and the meaningful work that they are doing. We think they're a great fit with HCI's mission, and specifically also the work of the Office of Healthcare Affordability. We can't rein in costs without data exchange. While we still have folks getting so many duplicative treatments, diagnostic tests, it's hard to have the high value and affordable system that we need in California. And the report card and other work done by the Office of the Patient Advocate is also critical to high value healthcare system. We've already had synergies with Margaretta's team working on the health and equity measures, for example, working alongside OPA. So it'll be wonderful to have those folks in-house and to continue that collaboration. So again, they officially come over August 1st. So we will be learning from incoming staff as well as stakeholders about what opportunities there may be to accelerate and improve that work. And then we'll be synthesizing what we hear from stakeholders for a going forward plan. For HCI's workforce development programs, we're very proud of the work that we've done this month to launch the 2 new BH Connect waiver provisions of the behavioral health workforce components of BH Connect. So BH Connect is a Medicaid waiver that was negotiated just in the nick of time in December of 2024. CMS just last week released a notice saying that they will no longer be approving waivers to support workforce development work. So it's particularly meaningful that California was able to do so before that change, before that pivot was made. So we have launched our first 2 BH Connect programs with vast success, very proud of the team. So on July 1st, we launched the first program, our student loan repayment program, which provides funds to a wide range of behavioral health professionals with loan repayment in exchange for service obligation in a safety net setting to provide behavioral health services to Medi-Cal members. And we've already received more than 2,100 applications to date in just the first 3 weeks. The second BH Connect program, the Medi-Cal Behavioral Health Residency Training Program, launched last week, and it provides grants to residency and fellowship programs to increase the availability of general psychiatrists, child and adolescent psychiatrists, addiction psychiatrists, and addiction medicine physicians that are trained to serve in a Medi-Cal safety net settings. So let's see, I have a reminder to folks to speak into your microphones to make sure you can be heard in the room. And again, we're working on trying to get the mics fixed, and we'll continue to project. And with that, I will turn it over to Vishal Pagani to project his remarks.
Thank you, Director Landsberg. So today I'm going to highlight 2 articles, one related to health expenditure projections and one related to hospital prices. I'll also share an update on a cost and market impact review. Next slide, please. First, I'll highlight key findings from the 2025 CMS report on projected national health expenditures, focusing mostly on projections for 2024, as it's likely that the passage of H.R. 1 will influence projections through 2033. In 2024, total U.S. healthcare spending is projected to reach $5.3 trillion, averaging $15,610 per person. That reflects a per capita growth rate of 7.1%, slightly higher than the 7% growth seen in 2023, and the 6% average growth seen between 2020 and 2022. A large contributor of this growth was Medicaid, with per-person spending projected to increase 15.2%, reaching $10,951. That's more than double the 7.1% growth rate from 2023, and far above the 1.7% average seen in the 3 years prior. This acceleration is largely due to eligibility redeterminations, which removed many younger, lower-cost enrollees, leaving a smaller, higher acuity population and raising average costs. Private health insurance spending is projected to grow 7.7%, reaching $7,608 per person. This reflects strong utilization, increased marketplace enrollment, and elevated spending on brand name drugs. While slower than the 9.7% growth observed in 2023, it remains well above the 2020 to 2022 average of 4.1%. Going on to Medicare, spending is projected to increase 6.7%, averaging $16,860 per person. Growth is fueled by continued enrollment gains and a sharp increase in prescription drug spending as a result of Inflation Reduction Act provisions that expanded low-income subsidies and eliminated catastrophic cost sharing for Part D beneficiaries. Going on to the next slide, I'll continue with NHE, or National Health Expenditure projections for 2024. The insured rate peaked at 92.5% in 2023. This was a record high before declining slightly to 92.1% in 2024, as Medicaid redeterminations were partially offset by gains in marketplace and employer coverage. Much of the spending growth in 2024 is primarily attributed to continued post-pandemic increases in the use of services and goods, particularly among people with private insurance, where utilization remains strong. Healthcare prices are expected to rise by 3% in 2024, matching the pace from 2023, but still running above the 2.5% average seen during the 2020 to 2022 period. Now I'll go over a closer look at the three largest spending categories in 2024. These are the same as those in 2023. The first is hospital care, which accounts for about 32% of total health spending, is projected to grow by 9.2%. That's a slight slowdown from 10.4% in 2023, but still well above the 2.9% average seen from 2020 to 2022. 2023 and 2024 mark the fastest hospital spending growth since 1990. Going on to physician and clinical services, which make up 20% of national health expenditures, these are projected to increase by 7.8%, just above the 7.4% growth in 2023, and higher than the average, and higher than the 6% average over the prior 3 years. Prescription drug spending represents 9% of total spending, is expected to rise 10.1%, although down slightly from 11.4% in 2023. The 10.1% growth remains well above the 2020 to 2022 average of 6.2%. This was driven by continued demand for high-cost specialty and chronic condition drugs. In summary, 2024 is projected to continue the recent trend of accelerated healthcare spending, driven by a mix of shifting insurance coverage, increased utilization of services, and steadily rising prices. Next slide. CMS characterizes 2026 and 2027 as a transitional phase, with growth averaging 5.6% as post-pandemic utilization levels off and enhanced marketplace subsidies expire. From 2028 through 2033, spending is projected to stabilize at 4.8% annually. During this period, private health insurance is expected to grow the slowest at 4.2%, while Medicare and Medicaid continue to grow more quickly at 5.8% and 5.4% respectively. For Medicare and Medicaid, this is driven by rising prices and ongoing I'm just going to back up for a minute. The trends for this period are driven by rising prices and ongoing demand. Importantly, these projections reflect current law and do not include the recently passed H.R. 1. I'll take us to our next slide, which is an article published in JAMA Health Forum earlier this month. So in this in this research study, they use claims data from 2020, the entire calendar year of 2020, and then a set of claims for the period of 2022 to 2023. They constructed a commercial to Medicare price ratio, which includes both inpatient and outpatient services, and examine how their relative price measure varies over time and across regions, as well as what characteristics are associated with higher hospital prices. Nationally, across the observed time period, the authors found that commercial to Medicare price ratios increased 5.5% from 233% and now up to 246%. Compared to the rest of the U.S., California had higher baseline prices with a commercial to Medicare ratio of 264% in 2020 and a faster growth rate of 11.7% from the period of 2020 to 2022 to 2023. The authors examined the relationship between market characteristics and these relative prices and found the following. Higher prices were more likely in areas with high hospital market concentration levels, areas with a major teaching hospital, a higher share of the population who are uninsured, and a population with a higher average income. Lower prices were more likely in areas with high insurer concentration levels. And I'll take us to the last slide of the executive update. I'd like to update the board and the public that on June 6th, OCA issued a determination to conduct its first cost and market impact review, looking at portions of a material change notice submitted by Covenant Care California regarding the transfer of skilled nursing facilities and assisted living facilities. The transfer includes assets, operations, and leases. The CMIR focuses on components of the transaction involving 3 Covenant Care skilled nursing facilities that will be operated by entities affiliated with the Ensign Group. After the transaction closes, the 3 facilities are listed here. OCA will publish its preliminary CMIR report on our website. There will be a 10-day business period for parties and the public to submit written comments in response to our findings. And I'll turn it back over to I have one more slide, and then I'll turn it back over to the chair. As I cover in every meeting, we have a slide formatting key. The yellow arrows indicate areas where the office has decision-making authority. We still want to get stakeholder input, including from the board. The green arrows just denote areas where the board has ultimate decision-making authority. Now I turn it back over to Chair Hernandez.
And again, apologies for the sound issues we're having in the room. We're going to need to reboot the system in order for the mics to work in the room. So why don't we go ahead and start with our Q&A from the board, and we'll do public testimony after a 5-minute break so that we can hear the public and get everything copacetic.
Sounds good.
Madam Chair.
Let me welcome Board Member Elizabeth Mitchell, who's now joined us. Don Molds, welcome to you. Thank you both for being here. I'll open it up to the board for any comments, questions with regard to the executive updates, which were many. Dr. Pan?
Thank you very much, Dr. Yanni, for your presentation. I guess a couple of questions. And so first of all, in terms of the National Health Expenditure Survey projections, of course, this is pre OBB, I guess the big beautiful bill, if that's is the technical name. I have other names for it, but I'll restrain myself. So I guess, is there any anticipation as to when they might revise those projections in light of the significant change in federal policy?
I haven't heard that yet. They typically do it on an annual cadence. We have the CBO projections.
Sure.
But yeah, if we do get an update, we'll report it to the board.
Okay, no, I appreciate that. Yeah, a lot of things are going to be very different. And then the other question is in the JAMA study, which shows basically California higher than Medi-Cal. I guess and they pointed to these different characteristics. I mean, you think about California, at least at the time, we actually have, I think, a lower uninsured rate because of the work we've done to expand coverage than the country, if I recall. And everyone has teaching hospitals, but and of course we're persistently higher. We also, I guess, we have a higher average income. We also have a higher cost of living as well. Is there a way to, I guess, and then I don't know whether hospital concentration is higher than everyone else or not, but so they have these factors, but is there a sense of like which factors weigh more and which one are more particular to California, or is it that's driving the fact that California for the entire period of time has been higher than the average in the United States?
The study did have coefficients for these various factors listed here. The hospital concentration was definitely the one that had the highest kind of coefficient. They did have an appendix with a supplement that included the California data, which is the graph that we generated. I'm not sure if they had like what these coefficients were at a state level, but they did for the overall study.
Okay. All right. No, I appreciate. I mean, I think trying to understand what is it that's driving this is going to be important, right? At least particularly to our state compared to other states in the country.
Yeah.
Is it because of our cost of living being higher and therefore people's incomes higher? Is it hopefully are we more do we have more hospital concentration in other states
I would
or not?
suspect it's based on other research that it's the concentration given kind of the literature on California's higher concentration in Northern California, and but yeah, that's something that we could watch out for in terms of if the study goes into more detail.
Okay. I would just note that California actually has a reputation of having lower healthcare costs than other states in many ways compared to, let's say, Massachusetts or someone else. So, so that's why I was curious about this.
Yeah. That could be true on costs, but the study in particular looks at prices for hospital services.
Okay. No, thank you.
Rick?
Just one quick follow-up on that. Most of the variation across market areas was unexplained. I mean, the R-squares were like 0.05, 0.07. So, these factors are related to the Medicare to commercial ratio, but most of the variation is, well, we're not really quite sure.
Ian, please.
Thanks. Just wanted to vouch on at least in the Taft-Hartley end of the universe, we're beginning to see the 2026 rate renewals come in, and they're in line with some of these projections, maybe even a little ahead of some of these projections in California, which has me very worried about the degree to which it's looking like they're going to overshoot the targets in 2026. I hope Board Member Moulds might forgive me for putting him on the spot. I know CalPERS, I believe CalPERS has just published its latest increases, and I think CalPERS is probably the most sophisticated large group purchaser in terms of connecting targets with rates. I'm just curious if there's been any discussion there.
These aren't working.
No, for the online.
Oh, okay. I got it. Yeah. So we just published our rates for, or we just adopted our rates for 26, and they're coming in at about 8.2% increase. Higher on the PPO side, higher on the Medicare side, actually. Our HMO rates are coming in at a little over 6.5%. I'm not sure what else I could add to that. They're better than they have been for the two previous years, but our rates are largely a reflection of healthcare spending, so combination of prices and utilization, but there are other factors that come in that bear on them as well.
Elizabeth?
Thank you. I would also just add to your specific question. Kaiser presents annually to our members about rate increases, and it was probably double the target this year. So yes, there's clearly some gap between our targets and what's actually happening. I also, though, well, one other thing from this article, which I think is a really important article, it says the findings provide evidence against the presumption that high commercial prices were primarily used to offset losses from public payers and instead contributed to higher profits for the hospital. So I do think understanding where some of that money is going is also important. But my question was actually on your other list of primary drivers, which were hospital prices, drug prices, the norm. Where is the examination of administrative costs from plans and PBMs? Because there's so much spread pricing in there. And, you know, now we're starting to be able to see like what claim amount was paid versus what the cost was. And there's a whole lot unexplained in between. So how are we getting at administrative costs as well?
We do collect administrative costs and profits for health plans, and those are publicly filed, so we do include that in our total healthcare expenditures. For providers, we won't be able to get to that level of detail. It's kind of baked into the rates that they charge and the reimbursements that they get paid. You know, since we rely on payer payments to providers, that's kind of, we won't be able to get to that level of specificity. But the hospitals, at least for hospitals, they do report their financial statements, so we could see the administrative costs and profits. Physician organizations do not currently file. They do for risk-bearing organizations with DMHC, and OCA does have the authority in our statute to collect financial statements from the non-RBO physician organizations, so that could be something in the future that we have greater insight into.
I think that's a big opportunity to address costs without, you know, harming access or quality or anything else. But it's at the administrative entity, like the health plan or the, you know, the myriad of vendors in between. So if there's a source for that information, I think it would be really helpful.
So, and I should add as the director mentioned at the beginning, the PBM information, that'll help start filling in some of the gaps as well.
Dr. Pan?
A quick follow-up to board member Mitchell's comment. You know, one of the things I'm concerned about is when we put the medical loss ratio caps on plans, I think there was also an effort to push administrative costs into practices where you won't see them because they're not considered administrative costs because it's part of the bill, right? It's sort of baked in. But driving up those costs with things like pre-authorizations and other types of things, those burdens basically is an additional cost, and frankly, one that not only increases administrative costs, but also denies people care.
Anything else from the board? Yeah, Don, please.
I'll just add one other thing, which is that, you know, I think we're all watching, or we all watched the major changes at the federal level and are deeply concerned about how they are likely to affect healthcare in California on many different levels, starting with the profound losses in coverage, but also numerous ripple effects. And to the extent that we are in a position to capture some of those, I think it's really critical information. I know that we have made the, and we've done this with our partners at Purchaser Business Group on Health, but made the case that the commercial market is likely to be detrimentally affected by some of these changes. I think to the extent that we are in a position to memorialize that, that is very powerful information. I think the folks in the commercial market have different kind of relationships with folks in Congress and with this administration in some instances, and I think their voice is a different voice. Would be terrific to have data coming out of here to the extent that it is possible to generate to further that conversation. But you know, we are bracing for some very bad things to happen, and we've made such tremendous progress over the last decade and a half in healthcare nationally, but especially in California. Anything that we can be doing to push back and to try to restore some of those gains is as important as anything else that we will be doing.
Let me make a few comments. One is Elizabeth started with acknowledging the 35th anniversary of the ADA, and I do think it's important for the board to also acknowledge the importance of that piece of legislation and how many folks who have had the opportunity to take advantage of that legislation. So I wanted to do that. Elizabeth also mentioned data exchange, the data exchange framework, and I think there are still opportunities in the state for us to achieve administrative savings through really implementation of the framework. So I'm really excited that it's coming over to OCA. I think it is in the right place.
To HCI.
Sorry, to HCI.
Sorry.
Did blood pressure, does your blood pressure go up?
Vishal has a lot on his
Did
plate.
your blood pressure go up there? Noted, noted. But we do have a lot of friction in our system, and consumers experience that friction in a way that does not necessarily benefit their health. And so I'm just really excited about that transition.
As are we.
And then just to put a fine point on Don's comment, no one has really started to think, I think, from a policy point of view about this ripple effect that we will see in commercial plans. And I do think it's important for us to capture the baseline of where we are today and begin to understand the ripple effects that HR 1 will surely have in California. So with that, I will open it up for public comment.
We're going to take a quick break while they reset the system. Hopefully it'll only take 2 to 5 minutes, and then we'll take public comment.
Turning these off, or
I don't know that
You can mute them.
okay, so let's open it up for public comment on anything related to the executive director or Vishal's updates this morning.
We will now recognize members of the public for comment on this agenda item. Please reserve comments on other items for the general public comment period. To ensure equitable access to verbal public comment, we will alternate between members of the public present in this room and those attending virtually. Those in this room may step to the podium. Those attending virtually may raise your hand. Those dialing in can press *5. During the comment period, you will be unmuted when it's your turn. We also invite you to provide written comment at the email address provided on today's agenda for the meeting. Please keep your comments to 2 minutes or less so we can hear from as many members of the public as possible. Please note that while the Healthcare Affordability Board is committed to communication and transparency, board members and staff will not be responding to public comment. Additionally, the board may not discuss or act on any matter raised during the public comment period that is not included on the meeting agenda today, except to place the matter on a future meeting agenda. I will start with the individual at the podium. Please go ahead.
Beth Capel for Health Access California. Thanks to the board and to the vice chair and the chair, the absent but soon to return chair, for recognizing the importance of the Americans with Disabilities Act, something which I have known about more personally than I would have hoped. So thank you all for starting with recognizing that. Second, with respect to HR 1, we were so very close to universal coverage, but the combination of HR 1 and the actions taken in the state budget have really taken us backwards. In effect, we've repealed half the ACA Medicaid expansion. In effect, we repealed half the Health for All expansion to the undocumented. Both of these measures taken together have limited coverage for lawfully present immigrants in ways not contemplated since the late 1980s. Even Pete Wilson did not go this far in terms of limiting coverage for lawful immigrants. The consequences for the Californians who lose coverage are dire. They do not get basic care. What they get in the hospital emergency room is the bare minimum of care, what someone described to me yesterday as enough care that the patient would not die in the emergency room. They don't get primary and preventive care. They don't get prescription drugs. They don't get comprehensive hospital care. A kid with an asthma attack gets an inhalation treatment, but not the $8 albuterol inhaler unless the hospital or the physician is kind enough to give it to them. We'll have more to say when this item comes up later in today's agenda, but that harsh reality is going to hang over all that we talk about here. As we were close to universal coverage, we were having a very different conversation. And I just want to acknowledge the pain and the fact that so many of us, as I look around, lived that pre-ACA reality. And there are some who have not. There are some, the ACA was 15 years ago. And there are people who have forgotten what an enormous difference it made and the other changes. Thank you. We will come back and comment later at that item on the agenda.
Oh, looking virtually, seeing no hands, back to the podium.
Hi, everybody. Ben Johnson from the California Hospital Association. Certainly align ourselves with comments from the board around concerns on the federal reconciliation bill, as well as can say with colleague Beth Capel from Health Access there. Do want to certainly encourage OCA to really use balanced, data-driven information in guiding decisions in this new environment. As for the material that was covered in the executive updates, would on the hospital study certainly second comments from Dr. Pan, Dr. Kronik on the study of hospital pricing, raising lots of questions, not explaining significant variation, and so forth. We encourage analysis of why premiums are going up for large purchasers such as CalPERS, and what this will mean for affordability, as well as for insurance profits if actual expenditures are being more limited to the spending targets that OCA has adopted. We are disappointed in the slides to see, I think, a real exclusive focus on the provision of care as the barrier to affordability here. And we think OCA is missing a clear opportunity to improve affordability without restricting access. As OCA's own baseline report showed, 21 cents of every dollar increase in healthcare spending last year just supported higher insurance company profits rather than patient care. Longer term, the national health expenditure data support this, elevated profits higher than what per capita spending are growing at. And so we're seeing very significant premium growth, as well as very high reserves, as shown by Department of Managed Healthcare data. And so while there are hundreds or sometimes thousands of providers serving the California healthcare market, just 4 health insurance companies control about 90% of the large group insurance market. And this incredible concentration provides them both leverage in negotiations with providers, but also with the purchasers that are buying insurance from
2
them.
minutes.
And a key barrier to healthcare affordability in the form of potential excess profits there. So now is the time for OCA to stop giving health insurance companies a free pass, increase scrutiny on this important sector. Thank you.
Thank you. Looking virtually, seeing no hands raised, noting for the record, we have about 90 virtual attendees. Seeing no one at the podium, that concludes public comment on this item.
Thank you. We're going to defer our minutes and our appointment of advisory committee members until the secretary joins us. And so what I'd like to do now is move to item 5A, an update on behavioral health spending definition and measurement methodology. Margarita Brandt, please.
Good morning, members of the board. Today, Debbie and I will provide an update on the progress on the behavioral health workstream since we met with you last month. We'll briefly summarize the status of the behavioral health work, then we'll review the definitions for claims and non-claims behavioral health spending, touching on the remaining issues and our recommendations for addressing them. And we'll conclude with a review of the process over the coming several months to finalize and disseminate the definitions so that data submitters can begin to use them next year. Next slide. So as we usually do, just a reminder of our statutory requirements related to behavioral health. We have two related but distinct activities for behavioral health spending. The first is to measure the percentage of total healthcare spending that goes towards behavioral healthcare. And the second is that OCA is required to set a benchmark for behavioral health spending that sustains infrastructure and capacity and shifts resources from specialty care towards supporting care improvement in behavioral health. The statute does not require that OCA set a benchmark by a specific date. And then on our next slide, wanted to provide a few updates on our behavioral health work and a recap of where we are. So at last month's meeting, we discussed the benchmark and the challenges of setting a benchmark either for annual improvements or an absolute level of behavioral health spending, faced with the uncertainty about current levels of spending and what might be realistic to expect in terms of improvement. The board therefore agreed to wait for at least a year till next year to adopt a benchmark. The current plan is for the board to revisit the benchmark in summer of 2026 with the benefit of additional data and analysis and experience to inform benchmark deliberations. This means that the payers that submit data next year, that this data will only be used for measurement and reporting, not for comparison against a benchmark. So moving to the next slide, wanted to start with a review of our behavioral health spending measurement approach and timeline. So for OCA's measurement responsibility, payers will submit data on behavioral health spending for the first time in fall of 2026. The data will cover years 2024 and 2025, and OCA plans to release a report on this spending for 2024 and 2025 in summer of 2027. And in accordance with statute and state regulation, the entities required to submit data for this purpose are payers and integrated delivery systems that provide coverage for at least 40,000 lives in the commercial, Medicare Advantage, and/or Medi-Cal markets. So, and on the next slide, we'll walk through a bit more detail. So starting next year, payers will submit data on claims and non-claims payments for behavioral health care using the definitions that OCA has developed in collaboration with our investment and payment work group. The detailed methodology will be included in an updated data submission guide that OCA will release to payers in the spring of 2026. The data will be aggregated by performance year and market category. There will be no patient or provider level data here. The HPD, or the Healthcare Payments Data Program, on the other hand, can support analysis of behavioral health spending and utilization at a more granular level to complement OCA's data collection. Spending will be sortable by service categories and subcategories for analysis and reporting purposes, and we'll walk through these in our definition in a bit. And this will include the ability to identify spending for mental health and substance use disorder services separately. And specifications for a behavioral health in primary care module will allow for certain services to be measured as part of both primary care and behavioral health spending without double counting them. So in the next section, we'll now turn to the definition and methodology for identifying behavioral health spending. We will look first at claims-based spending methodology and some final adjustments we are recommending here. And then we'll also provide a refresher of the approach to measuring non-claims behavioral health spending. And we're nearly ready to share the full definition for public comment and review. And we're looking forward to hearing your feedback and suggestions before we release the full definition for public comment. Also, as we approach the end or near the end of defining behavioral health spending, we really want to appreciate the members of the OCA Investment and Payment Work Group for their time and their thoughtfulness in working through the fine details of all aspects of the definition. So to start, if we could go to the next slide, these are the high-level principles on which OCA's methodology for measuring claims-based behavioral health spending is based. First, all claims with a primary behavioral health diagnosis will be included in the measurement of behavioral health spend. In addition, claims for screening and assessment of mental health or substance use disorder will be included in the measurement regardless of whether the claim includes a primary behavioral health diagnosis. Behavioral health claims will be categorized based on place of service, revenue, and service codes, and the categories are relevant for reporting purposes and later for identifying spending that could be included in a focused benchmark. Finally, a set of national drug codes or NDC codes will determine whether a pharmacy claim should be included as either mental health or substance use disorder spending independent of diagnosis. So if we could go to the next slide, this is a schematic representation of how a claim is identified as behavioral health spending. So to start, the main test is whether the claim includes a behavioral health diagnosis as its primary diagnosis. The exception to this is when a claim is for screening or assessment of a mental health condition or substance use disorder, which do not require a primary behavioral health diagnosis. The service subcategories and categories in the center of the diagram are defined by place of service, revenue, and service codes, and they are used only for reporting and analysis. Once a claim is determined to have a behavioral health diagnosis, this further categorization has no bearing on a claim being included as behavioral health spend. So any claim that cannot be categorized elsewhere will be categorized into other behavioral health services. Pharmacy claims are separately determined to be behavioral health spend based on NDC codes. And importantly, all claims can be identified as either mental health or substance use disorder spending. So these can be measured and reported separately. And then on the next slide, we wanted to walk through in a bit more detail our proposal and some recommendations for revising the reporting subcategories. So our original list of reporting subcategories included 12 subcategories. The detailed code set we have developed with the investment and payment work group specifies the combinations of place of service, revenue, and service code that place a claim into each of these subcategories. So claims, and I'll note again here that claims with a primary behavioral health diagnosis, but without a combination of other codes to place it in a subcategory, are assigned to the other behavioral health services. Subcategories can also be rolled up into the 6 reporting categories that are on the left of the chart. So over the course of our work with the investment and payment work group, an interest emerged in replacing the community-based mobile clinic services subcategory, which is highlighted in light blue on the slide, with a broader crisis care subcategory, and then further discussion about those services both in the work group and with other stakeholders revealed an interest in analyses of service utilization in both of those subcategories that would require more granular data than the OCA behavioral health data collection can provide. So the HPD would be a more appropriate data source for these detailed analyses. And based on this feedback and discussion with the investment and payment work group, we propose reducing data submitter burden by folding the community-based mobile clinic services and crisis care services into the other outpatient subcategories, the outpatient and community-based subcategories, rather than having specific subcategories for these areas of care. OCA is also recommending removing the long-term care subcategory. As we'll see shortly, spending in this subcategory rarely appears in the preliminary HPV analysis of behavioral health spend, and removing, reducing or removing this subcategory would reduce data submitter burden a bit to simplify the subcategories. So if we could go to the next slide. So this is a bit about the rationale for making these proposed revisions. So wanted to note here, most importantly, that changes to the subcategories do not affect total spending measurement, only the categorization of the behavioral health spending. Again, any claims with a primary behavioral health diagnosis that are not allocated to one of the subcategories would be counted as other behavioral health services. Simplifying the subcategories will reduce data submitter burden a bit, and OCA can use the HPD to measure and monitor changes in mobile clinic services, crisis care, and long-term care spend to better meet stakeholder interests. And also note that the subcategories we're proposing to remove would likely be used relatively infrequently. Preliminary HPD analysis showed little or no commercial or Medicare spending on mobile clinic services from 2018 to 2023, and about 4% of Medi-Cal behavioral health spend was for mobile clinic services during those years. I'll note that the preliminary HPD analysis did not include a crisis care subcategory, so we don't have an exact estimate of that spending, or we don't have an estimate of that spending. And the HPD analysis also found very little behavioral health spending in the long-term care subcategory across all payers. On the next few slides, we'll review the behavioral health, the commercial behavioral health spending results from HPD, the preliminary analysis that we reviewed last month. So this is commercial behavioral health spending by subcategory for 2018 through 2023 as a percent of total behavioral health spending. The table organizes the subcategories from the largest portion of overall behavioral health spend at the top down to the lowest at the bottom. And note that mobile services, second from the bottom, makes up a negligible contribution to total behavioral health spending, never more than 0.1%, and approaching 0 in 2023. The long-term care subcategory is even smaller, never more than 0.1%, and even less in 2023. And on the next slide, last month the board asked to see this preliminary analysis of historical behavioral health spending disaggregated into mental health and substance use disorder spending. So this slide and the next include that data. For mental health, which is the bulk of behavioral health spending, the rank ordering of subcategories is the same as behavioral health overall. The percentages of total mental health spend for the first three subcategories, outpatient, professional, non-primary care, pharmacy, and inpatient facility, are slightly higher than they are for the distribution of all behavioral health spending. And as with overall behavioral health spending for mental health services in the mobile services and long-term care subcategories are very small in the HPD data. And then in contrast, for substance use disorder services, most care is concentrated in facilities, or most spending is concentrated in facilities, inpatient, residential, outpatient, and emergency departments. Professional and pharmacy claims are much lower here relative to their contributions to total mental health spending. And as with mental health, there's very little spending in long-term care or mobile services subcategories. So in the next slide, using this information, we are proposing to revise our subcategories to a list of 10, removing mobile services and long-term care. Spending on mobile services will be grouped with outpatient subcategories such as outpatient professional non-primary care, and long-term care spending will be folded into the other subcategory. The structure remains the same, the overall structure with the subcategories rolling up into categories for the purposes of reporting, and of course, the behavioral health claims that do not fit into any other subcategory will be assigned to other. So with that review of our proposed revisions to the claims-based portion of the definition, I'll now turn the presentation over to Debbie Lindis, Healthcare Delivery System Group Manager, to review the proposed approach for identifying non-claims behavioral health spending.
Thanks, Margareta, and good morning. On the next slide, I will start by reviewing the principles for our non-claims measurement definition. So that measurement will involve a variety of methodologies for allocating some or all of a payment to behavioral health care. We will classify non-claims payments using the expanded non-claims payments framework that we've developed with our colleagues at Friedman Healthcare. And it's the same framework being used to classify non-claims payments in OCA's total medical expense, alternative payment model, and primary care spending data collections. So those measurement methods include classifying payments for population health, behavioral health integration, and care management as behavioral health only when those payments are made to behavioral health providers, limiting the portion that can be attributed to behavioral health care from payments for practice transformation, information technology infrastructure, and analytics, including 100% of behavioral health capitation payments, and allocating to behavioral health care a portion of other types of capitation payments using a formula similar to the one adopted for allocating capitation payments in primary care. On the next slide, and the two after that, we'll review the specific approaches OCA recommends for allocating non-claims spending in the expanded framework subcategories to behavioral health care. So starting with expanded framework category A, population health and practice infrastructure payments, the payments for subcategories A1 through A3 would be considered behavioral health spending if and only if they're made to behavioral health providers and provider organizations. And all subcategory A2 payments for primary care and behavioral health integration would be included in the behavioral health in primary care module as part of behavioral health spend. The spending in subcategories A4 and A5 would be limited to a maximum allowable amount. And OCA recommends that that limit be equal to the portion of total claims and capitation payments going to behavioral health. In other words, the amount of practice transformation and infrastructure payments attributable to behavioral health would reflect the proportion of spending for behavioral health care in claims and capitation payments overall. And we'll look at this a little more closely in just a moment. So for category B, performance payments, they'll be recognized as behavioral health care payments when they're made to behavioral health care providers. Go to the next slide to look at category C, which is shared savings arrangements. So condition-related episode-based payments would be included in the measurement of behavioral health spending if the episode of care in question is behavioral health related. We're not aware of existing or planned procedure-related episode payments for behavioral health, and nor are we aware of health plan arrangements with behavioral health practices agreeing to take on risk for the total cost of care, and so no payments in those subcategories will be considered behavioral health spending. On the next slide, we'll look at capitation payments. So for behavioral health capitation payments, subcategory D4, 100% of those payments would be included in behavioral health spending measurement. For more general types of capitation, professional and global, and payments to integrated comprehensive systems, the behavioral health portion would be allocated using a similar formula to what we use for allocating capitation payments in primary care based on encountered data. And as with primary care, facility capitation payments would not have a portion allocated to behavioral health spending. Payments in Category E, other non-claims payments, would be limited to a maximum level using the same proportional method that we're recommending for the infrastructure and practice transformation payments in subcategory A4 and A5. And on the next slide is an illustration of the formula for determining that maximum amount of non-claims payments allocated to behavioral health care for subcategories A4 and A5 and Category E. So this example is for a subcategory A4, practice transformation payments. And the formula shows that the behavioral health spend for subcategory A4 equals the product of all practice transformation payments and the ratio of behavioral health claims and capitation payments to total claims, capitation, and other full risk payments. So in other words, for example, behavioral health claims and capitation, if they are 6% of total claims and capitation payments, then the maximum amount of subcategory A4 payments a payer could allocate to behavioral health care would also be 6%. Going to the next slide, we have the formula for the proposed approach to apportion professional and global capitation payments to behavioral health care. So for this example of a professional capitation payments, data submitters would calculate a ratio of fee-for-service equivalents for behavioral health care services to fee-for-service equivalents for all services in the capitation. And then that ratio would be multiplied by the capitation payment amount. And as a reminder, these data will come from payers and not directly from the provider organizations that ultimately decide how to allocate capitation dollars. So this formula serves as a best estimate rather than a precise measurement of capitation dollars spent on behavioral health care. And this is the same methodology that would be used to determine behavioral health portions of payments to integrated comprehensive payment and delivery systems. Go to the next slide. And so to wrap up, we are providing here a detailed timeline for the process of finalizing our behavioral health definition and measurement methodology. So the investment and payment work group met last week and discussed some of the remaining issues with the definition. And following today's board meeting, OCA will prepare the definition and methodology to release it for public comment, which we plan to do by August 1st. The 30-day public comment period will extend through the month of August, ending around the 30th of the month. And then at its September 22nd meeting, the advisory committee will review the public comments to the proposed definition and OCA's responses to those comments. And finally, in October, OCA will finalize the definitions as they will be incorporated into the 2026 data submission guide for payers. OCA will update the board on the finalized definitions as part of its review of the data submission guide for 2026 in October or some other time this fall. And also, importantly, over the course of this summer and fall, OCA will be meeting with DHCS and Medi-Cal managed care plans to review the definitions and ensure that they reflect the managed care plans spending. And we can go to our very last slide. And so to close, I invite members of the board to offer any additional feedback you may have regarding OCA's proposed behavioral health definition and measurement methodology.
Thank you. And I'm sorry I missed last month's meeting. First of all, I have no problems with the recommended eliminations of categories. That makes sense to me. What I'm worried about is the primary care piece. Our members are really committed to integrated behavioral health and primary care, and it's very hard to push that. And I'm just worried that this could become a deterrent, particularly if it's only going to be recognized if it's a primary diagnosis, because there may be secondary other diagnoses, I mean, that we still want to capture. And also this seems to really emphasize payments only to behavioral health providers as opposed to primary care providers who may be doing some mental health care treatment. And so what I really don't want to do is, encourage ongoing fragmentation, like an incentivization of like carve-outs, because we know that the integration is better. So is there a way to reconsider just the primary care piece so it better reflects the reality of what the primary care practices are trying to do? Also, we are, part of my organization has been running a practice transformation initiative with practices trying to do this integration, and many times the plans won't recognize the behavioral health work, so there may not be a code or a payment even though the work was done. So I think that's another challenge to overcome.
Yeah, thank you for those comments and suggestions. So we didn't present the details here, but we have this separate behavioral health and primary care module, which aims to capture a lot of what you're talking about. That will include behavioral health care that's delivered in primary care settings by primary care providers. The caveat being that this primary behavioral health diagnosis is part of our definition, and we recognize that in the current state that is going to miss some. I think that it's one of those overcounting, undercounting concerns that we have, that if we capture behavioral health anywhere on the diagnosis list, anywhere on the claim list, then we would overcount a lot of care that wasn't primarily behavioral health care. And we've had a lot of back and forth conversations with our investment and payment work group, which includes a lot of primary care physicians and other clinicians who have given us input on that. So we recognize that that's a limitation, and we hope that there will be movement to encourage primary care providers to use primary care behavioral health diagnoses. But integrated behavioral health codes are very much included in that module. And so since we're measuring it separately, really hope that that will incentivize plans and others to use those codes more and provide those services more.
Thank you. And actually, again, follow up to Board Member Mitchell's question. So a couple of, so first of all, I note in your initial chart, your process map, it says claim includes code for mental health or substance use screening or assessment. And that's actually, well, I'm a pediatrician. When I do well child, I do a lot of screening. So do those health supervision or well child visits get included or not? That's part of the, in fact, if you look at the guidelines, the Bright Futures guidelines, which is the standard sort of Bible for well child care, you see these screening tools that you're supposed to use. I don't know whether people code them separately from the well child code, but it's in there. So does that get included or not? And I assume on the adult side, you're going to see similar things.
Yeah, so those codes are included. That line on the claim is included. So depends on providers coding it, which they
Sure.
often do not. And then the payment amount for that may be zero if that is not paid for. But anything that is paid for those procedures that are separate from the 992 visit is included in our
Okay.
measurement, regardless of any resulting behavioral health diagnosis.
Okay, so that's helpful to know. And first of all, I want to express my appreciation for the work here because it's hard to untangle this. There's a lot of stuff that's tangled together. So trying to figure out, and you said the undercount, overcount issue that starts happening as you're trying to untangle these things, what's going on. So I want to acknowledge that. I think one of the things that, and just to share Board Member Mitchell's concern, is that as we put this benchmark and the way we count things and how the health plans, which codes they allow and how much they encourage or incentivize the use of those codes will drive behavior, right? So what happens is that if they have a set of codes that primary care doctors can use, but they don't really emphasize that you need to code for that, or they don't reimburse separately for those codes, then they're not going to code for that, right, at the provider end. And if they don't code for it, you're not going to capture it. And then what will happen is that when you say, oh, by the way, plan, you need to increase your behavioral health because you're missing the benchmark, they're not going to go and, they're not, they're not going to encourage the primary care doctors to do this. They're going to, so in other words, we're going to create this greater divide. And unfortunately that has happened. I get it. You had mental health carve outs and stuff. And basically, but we're the ones in the front lines as primary care doctors who are saying, we can actually we get trained to take care of a lot of basic mental health problems. So it doesn't need to go to a specialist necessarily in all cases, or we co-manage, right? But if that isn't captured, then what will happen is that we may actually incentivize behavior that pulls primary behavioral health out of the primary care, which actually may turn out to be more expensive too. So as I'm thinking about this, and again, appreciate all the work that you're doing. Some of it is we're thinking about this benchmark. Perhaps it's not just the measurement end in terms of doing the hard work that you've done here, but also asking the plans and actually challenging the plans and measuring what they're doing in terms of, okay, are your primary care doctors using the kind of code so we can capture that or not? What are you doing to be sure those primary care doctors are incentivized to put those codes because so that we can capture it, because that's the mechanism by which we capture it. Otherwise, I think we're going to miss things, but not only miss it, we're going to actually, because as we put pressure on plans to hit the benchmark, we're going to encourage behaviors that may actually be, I don't say counterproductive, not right, but not optimal to being sure people have access at the primary care level, and also in terms of actually even trying to improve affordability as much as we could. So not through intention, but as a side effect of our actions. So I just guess throw that out there for some consideration. Again, recognizing how hard this work is, but also as we're doing this, how our method of measurement may also shape behaviors, and how we might want to think about how we want to shape behaviors in a way to get what we want. Thank you.
Thanks, and I'd like to echo the appreciation for what a complex subject matter this is and how you're approaching it. I had 2 points and 2 questions maybe. First off, I speculate that there is going to be less federal focus on non-quantitative treatment limitation enforcement and other mental health parity, and there's therefore more onus on DMHC and the DOI to enforce those. And I would love to see as much parallelism or synergy between the metrics we're creating here and the data they need to enforce those parity laws. Second observation, I can imagine a number of compelling arguments on both sides of whether or not we want to include drug spending here in the benchmark, and it's not something we have to sort out now, but I think by the time we're looking at defining that benchmark and incentivizing the health system around that, it would be really helpful to have a good public airing of the pros and cons of including or excluding drug claims in the benchmark. I guess the two questions on the allocation of capitated payments. As I understand it, we're going to take the volume of encounters and multiply it by some industry benchmark fee-for-service equivalent payment. And I am concerned about that because for whatever reason, this section of the healthcare workforce is functioning differently from other sections. When we're looking at hospitals or hospital-related professional fees, we're looking at multiples of Medicare as the norm for reimbursement rates in the commercial sector, whereas I believe for behavioral health, providers are often compensated at or even below Medicare rates. And I suspect that has a lot to do with some of the workforce dynamics. And so my concern is that in a world in which perhaps plans are motivated to discourage people who need robust behavioral health support services from being in their plans, the allocating to them a kind of industry standard benchmark might incentivize them to make capitated payments that are not actually going to behavioral health. And I understand the challenge that we're collecting this data from the plans, but I also heard that DMHC captures some data from risk-bearing physician groups. There might be other sources of data out there, and I'm wondering if you've put any thought into how we make sure that those funds are actually flowing to behavioral health.
So the capitation allocation methodology is, is an estimation of behavioral health spending under capitation, and we recognize its limitations with using encounter data. I'll note that the instructions are to use the plan's specific fee-for-service reimbursements rate, not a standardized Medicare rate or other rate. They are supposed to use their specific fee-for-service reimbursement rates, and based on market, geography, if they differ by payer type. So it's intended to aim to be more specific through our instructions. But we do recognize that under capitation, allocating a portion to behavioral health spend is an estimate, and we can look to, continue discussions of collecting data from risk-bearing organizations or other ways to try to check the capitation amount for going to behavioral health.
Thank you. I had missed that it was a plan-specific fee-for-service equivalent rate, so that's very helpful to understand. I think my other question, just back on the question of out-of-pocket spending that we've grappled with a lot here. Again, obviously, we're not going to get that data from the plans by definition. Have you had any further thought into what tools would best equip you to fold some estimation of that in here?
We wouldn't fold it into this estimate because this is total medical expense data that it's from the plans. It's kind of what actually was spent. We did have that separate analysis where we're trying to estimate behavioral health out of pocket, out of plan spending. We are running into some issues with that in terms of it does kind of require a lot of assumptions and pooling of data across multiple years. And it was from, an extrapolation based on MEPS data. We will need to provide an update to the board on kind of the status of that. But, I would kind of treat those two as separate for now.
Thanks. I wanted to just make a couple of comments. First, I'm supportive of Elizabeth's point and Richard's points about creating incentives that encourage integrated care and the integration of primary care and behavioral health in particular. So, if we're asking the question about whether the greater harm is in undercounting or overcounting, I would say undercounting, because the incentive there that we should be creating is one where primary care providers are getting the training and providing the services that we want them to be providing. So, worst case scenario is it's marginally easier to hit a very high target. So it seems to me that we should push things in that direction. Again, I'll also echo I know this is complicated and it's easy to shoot from the hip on some of these, so I don't know how you draw some of those lines, but for things like secondary diagnosis work, that may be there, maybe somewhere else, I don't know. The other thing that I just in thinking about this, I totally appreciate why we're not asking to report out on long-term care or mobile services on the one hand. On the other hand, I think it's really important that we understand the general direction over time that services are going, and particularly in the behavioral health space. one reason, just a hypothesis, why mobile services is barely a blip is because it's really cheap. And if we get into this situation where those kinds of services are actually really effective, at the end of the day, we're all here trying to reduce spending, and leaning into highly efficient interventions is something that is a very good thing. But if we're not at least keeping track of what's going on in the market, we have no idea whether what's happening is efficiency or missed opportunities. So I don't know how you do that either, but I'm just throwing that out as, I do know how you do it. You would probably figure out some sort of non-percent of spending way of measuring that. But in those instances, I think it's important that we keep track of the market so we understand what's happening better.
Thanks. I support the suggestion to not have mobile services and long-term care as separate reporting categories. And I think the HPD can keep track of this. I don't think this needs to get done through this mechanism. Yeah, no, I agree. And I think the HPD, as far as I understand, is a good way of keeping track of this. And I support also certainly the integration mantra, but would be anxious about identifying claims with secondary behavioral health diagnoses as mental health or substance abuse services. Certainly on the inpatient side, I think that would be a mistake. Many people get admitted, primary diagnosis is diabetes or heart failure. They also have depression. They're not getting behavioral health services primarily in the hospital. Little less clear, maybe somewhat more arguable on the ambulatory side, but even there, I think there are many people who go to the physician for all kinds of problems, and they also have depression, and maybe the depression contributes to the complexity of the visit, and it's perfectly legitimate, and the physician actually is supposed to code depression, but it's not a behavioral health service. It's not what the physician is treating the patient for. And so I would be anxious about including any service with a secondary behavioral health diagnosis as a behavioral health service. And I see, Richard, you want to respond, but just while I have the mic, I would ask Vishal, Ian asked about the non-plan, out-of-pocket non-plan services. I appreciate the MEPS work that you did earlier. It's pretty clear that's not going to be sufficient to get where we need. And I would ask for a timeline on, another strategy. I think I had mentioned in the last meeting that perhaps some, money could be found to do a survey of therapists and other behavioral health providers to understand from their point of view, what their revenue streams look like and how much of their revenue is coming from out-of-pocket payments. And that might be a way of getting at this. And then I will also channel my fellow board member who can speak for herself, but having some timeline or some understanding of how the behavioral health spending from county mental health agencies is going to be included in here. And that's clearly, as Sandra has more eloquently said than I, a really important part of the behavioral health landscape in California. And I know that's not what you're focused on here, but having a timeline for what's going to happen, how we're going to deal with those data, I think is important as we move forward. But Richard, sorry, yeah.
So actually, I am of some mixed mind about what to do about secondary diagnoses, especially in the primary care setting. I agree with you that probably in the hospital, it's like, oh, they have depression, add on. The challenge in the primary care level. So, for example, actually, interesting enough, I got an email from the medical director at the FQHC that I practice at, saying that we're trying to set up this clinic, and Richard, do you know, can we bill for both mental health and physical health on the same day And in Medi-Cal, I said no, because currently the rules don't allow that. It has to do with PPS payments and stuff. And actually, interesting enough, I know that Senator Atkins and I tried to work to see if there's a way we can untangle that so we could do that, right? Because we do know patients come in for both. And so, we instead of sending them out and telling them to come back another day, we'd like to take care of both. And so, but why do I bring that up? It's because, well, if you technically can't bill for both, what do you code for? Right? And if you're a primary care doctor, you're probably going to more lean toward coding the medical, even when you provide the mental health part, and you just don't get paid for it, right? Because why bother, right? And in fact, you're not allowed to bill for both. So, all you do is you get the billers going, which, et cetera. So the question then is on the primary care side is when you do have a secondary mental health diagnosis, how much, as you raised appropriately, how much mental health care did you really provide? You see someone for, let's say, high blood pressure management, depression, all these things. And then, and I think that because generally behavioral health is not maybe carved out or something, you generally tend, I think you develop a habit. I can't speak for everybody. I didn't do a survey of all primary care doctors, to probably put the medical stuff first because that's more likely to get paid for than the mental health, even if you spent most of the visit doing mental health care, right? So I said mixed mind, because I agree with you that but I'm not so sure. I think we have some challenges in terms of how sort of the coding behavior of primary care providers, given the environment they've been coding, the billing environment they've been living in, how that probably affects. And so therefore, when you say what's primary and what's secondary, and what do they really spend their time on? I guess unless you can go into their chart and see. I mean, that's the other thing. You could, that may make it too complicated, but could you dig into something and find out whether, how much, was it simply they added it on or they actually did something with it? That may be, that's not an administrative data. So, but I know that if we don't count secondary, we're going to miss a bunch. If we do include it, we may, again, pick up too much. And the question is which way we lean, or is it possible to find some other signs that you say, okay, well, you have a diagnosis and some other sign, if it's secondary, that, change in medication or whatever, which maybe gets us closer to not missing as much. There's still times you see someone, you're monitoring them, and current plan's fine, but you still spent time on it. So yeah, I think that's the challenge of trying to figure out how to juggle it. And I don't envy our staff and our team to untangle that.
Sandra.
Yeah, complicated stuff. I want to appreciate all the work that's been done, thoughtful. I just want to put a fine point on a timeline for counting mental health. It's such an important part of our delivery system, so finding a means by which we figure out how to monitor that and categorize that, I think, is an important thing to do. I know you know this, but I haven't really seen it on a timeline. And so if there's a way to accelerate that in some fashion, I'm open to hearing that in any capacity in which I operate, perhaps. This point about primary care and behavioral health is super important, because the only way we're really going to get behavioral health at the scale we need it is for primary care providers to lean into it, to do more training in it, to feel more comfortable managing it. And so we shouldn't, in methodology, do anything that somehow disincentivizes our capturing of that effort. And maybe, just to be practical, sitting with a couple of plans to talk about how they think about that as a plan, because I suspect all of them are trying to figure out how to meet the mental health needs of their population, might be helpful to thinking about how we capture it without disincentivizing that integration, which is really incredibly important for access to behavioral health services.
Thank you. A lot for the team to think about, and potentially even more from the public. So I will, first of all, thank Vice Chair Hernandez for sitting in and chairing as we started off today, and I will invite the public for comment on this issue.
We'll now take public comment on this agenda item. If you're in the audience, please step to the podium. If you're attending virtually, please raise your hand. We will start with a virtual attendee. Abby, we see your hand raised. Go ahead.
Hello, good morning. My name is Abby Alvarez. I'm a policy advocate with the County Behavioral Health Directors Association. I first wanted to address the stated intent to quote, shift greater health resources and investments away from specialty care and toward supporting and facilitating in primary care, and just noting the need for precision in language on that, because in the behavioral health delivery system specifically, specialty care includes and refers to the public behavioral health delivery system, Medi-Cal members experiencing serious mental illness and substance use disorder. And I assume the goal is not, or that the goal is to improve primary care to prevent folks from needing specialty care and not to divest from the public behavioral health safety net system. That being said, even in referring to commercial care, there is a need for improvement in specialty care in addition to primary care. An example of this is responsibilities that commercial care has on first episode psychosis and need for improvement there. Effective specialty care in commercial settings reduce preventable disability and cost shifting onto the safety net setting. So thank you, and CBHDA would invite future discussion about the impact that behavioral health investments in commercial care have on the public safety net system. Thank you.
Thank you. Looking to the podium.
Beth Capel for Health Access California. Those comments would have enriched the discussion over the prior year or two in the investment and payment work group on behavioral health. We are fortunate that the law requires that there be measurement of the integration of behavioral health and primary care, and that that's a clear direction to the staff and the board. Not an accident, I might add. Some of us were well aware that the major chronic conditions are all highly correlated with depression, and that it is unclear where the which direction the causal arrows run. Does diabetes cause depression, or does having diabetes make it harder to manage depression? Or both ways, and both are true. So those who crafted the legislation anticipated that you would be having these conversations. I would also reflect on the folding in of long-term care and mobile units and crisis units, that they're emerging and evolving means of providing care. So mobile and crisis units particularly important on the Medi-Cal side, much less on the commercial side, so it doesn't particularly show up. So it's the need to adjust as we go forward will be an important part of this. And finally, as yet another example of the way in which H.R. 1 and the state budget hangs over this, we would note that the work requirement will make it hard for those working age adults who are unable to work for good reason, but who do not meet whatever the coming federal definition of disability is, to qualify for Medi-Cal. And so that will hang over this work and these discussions and the impacts on across the health system. Thank you.
Thank you. Looking back virtually, seeing no hands raised, noting for the record, we have about 76 virtual attendees. Back to the podium.
Hello, Chair, members of the board. My name is Kira Keegan. I'm with the National Union of Healthcare Workers. NUHW represents thousands of behavioral health providers across California in both community-based and institutional settings, working both directly with health plans and for their contractors. We'd like to thank OCA staff and board members for your work to capture plans' behavioral health spending accurately. We support the board's intention and really look forward to future updates regarding the inclusion of out-of-pocket spending on outpatient behavioral health care as part of measuring behavioral health spending. So the undue burden of this spending places upon consumers will be considered as we set behavioral health spending targets. A related issue that OCA must also take into account is the high number of behavioral health private practice non-physician clinicians that do not accept insurance payments, which a 2024 Health Affairs article found to be nearly half of California providers. Increasing behavioral health clinicians' participation in insurance is critical to increasing access to outpatient behavioral health care for patients, and evidence suggests that plans under reimbursement of behavioral health services may be a major factor keeping providers out of insurance networks. A 2024 study by RTI International revealed that in-network office visit reimbursement was significantly higher for medical surgical clinicians than for behavioral health clinicians. This prompted one of the study's consultants to comment that RTI concluded that high out-of-network use for mental health and substance use treatment cannot be explained by a shortage of behavioral health providers. If that were the explanation, we'd see the same out-of-network use disparities for primary care physicians, which are even in shorter supply than mental health providers. Another 2024 report from the National Academies of Sciences, Engineering, and Medicine recommends that HHS and CMS expand the behavioral health workforce participation in Medicare, Medicaid, and marketplace insurance by providing guidance to states on setting reimbursement rates for behavioral health care services that address the actual cost and adjust for undervaluation of these services. Thank you.
Thank you. Looking virtually, seeing no hands raised. Looking to the podium. Seeing no one at the podium, that concludes public comment on this item.
Thank you very much. We are going to return and appreciate the future conversations. Thank you very much. We are going to return to item 3. This is the consent item related to the June 9th, 2025 meeting minutes. Is that correct?
Yes, the minutes and any public comments we've received since the last meeting have been distributed.
Is there a motion?
So moved.
Second? I think are we doing roll call vote, please?
We'll now take public comment on this item.
Thank you.
If you'd like to make a comment on this item, please step to the podium, or virtually, please raise your hand. Seeing no hands raised and no one at the podium, that concludes public comment on this item. We are now ready for a vote. Dr. Sandra Hernandez?
Aye.
Secretary Kim Johnson?
Aye.
Richard Cronick?
Aye.
Ian Lewis?
Aye.
Elizabeth Mitchell?
Abstain.
Dr. Richard Pan?
Since I was absent, I abstain.
That's 4 in favor, 2 abstains. The motion passes.
Thank you. And we are going to move back to item 4 now. This is a vote to appoint advisory committee members and welcome Megan Brubaker, the Engagement and Governance Manager.
Thank you. So before we get to a discussion, I will share some information about the submission process, the applicant pool, the committee positions requiring appointments, and the subcommittee's recommendation. Next slide. So this process began earlier this year with solicitation for applications to join the advisory committee. That solicitation process closed on April 15th. After evaluating submissions in May, the subcommittee determined that an additional recruitment for physicians was needed. Subcommittee meetings were held in June and July to consider the submissions and form recommendations, and today the board is being presented with a potential slate of candidates for appointment. Next slide. With the first posting from April, we received 42 total submissions, and that includes 8 incumbents and 34 new applicants. After we received 25 additional submissions from physicians. Slide. This slide shows the current composition of the advisory committee, which includes 28 members. Highlighted in yellow are 12 outgoing positions, including 1 vacancy, Abby Ant, who retired earlier this year. If we go to the next slide, You can see the recommended slate of new or reappointed advisory committee members with stars next to each new or reappointed member. 9 of the 12 recommended appointments are reappointments. And I'll note that the subcommittee is recommending to reappoint every current member that sought reappointment. Next slide. Now I'll just go through some demographic information about the recommended slate. And this is for the entire advisory committee with the new appointments and reappointments. This slide shows which county each member is from. These are counties that span this state from the far north to the southern tip, includes the Central Valley as well as coastal regions, and comprises small, more rural counties and large urban centers. Next slide. Continuing with demographic information about the recommended slate, this slide shows the LGBT plus and gender identity composition of members. Next slide. And lastly, for demographics, this slide shows the race and ethnicity information of members. Next slide. So here is a draft motion from the subcommittee for the board to consider. First, approve the recommended advisory committee membership, which includes 28 members. Second, appoint the new and reappointed members for a 2-year term. I will now turn it over to our 2 board members who served on the subcommittee, Elizabeth and Richard Pan, to add any commentary and begin the discussion.
Thank you, and I really appreciate the opportunity again to work with Board Member Mitchell on the advisory subcommittee nominations. I think, first of all, I'd just say that as we were looking at the nominations and the vacancies and so forth, is that at least at this point in time, and we can have a discussion about how long someone should serve on the advisory committee, given the amount of work and the ramp up speed that we chose to essentially renominate anyone who was already on the subcommittee who was basically being a good contributor, et cetera, that and attending and so forth. So that's why people who were on the subcommittee who wanted reappointment, we essentially are recommending reappointment of those members. At some point, we may want to have a discussion about when do we want to start having some more turnover? But I think that given the nature of the work of this advisory committee, having 2-year terms, serving 4 years at least seems to make a bit of sense as long as someone's willing and interested in putting the work into doing that. So that's first point. Second of all, we did have some people who decided not to continue. Admittedly, the reason we ended up doing a second solicitation for the physician one is there was one of the appointees who was in the physician category, we did not know, was not interested in reappointment, or let's see, wasn't known at that time when we were soliciting candidates. So there were actually an absence of candidates in that category. So that's why we did a resolicitation, and wow, 25 people showed up in terms of, there's clearly a lot of interest in serving in this advisory subcommittee, and we were able to go over that and actually both agreed on the nominee that to fill that position as well. So without going into specifics on each candidate, but I think that's generally what we were working with and how we came to our recommendations to the board. And I guess, Dr. Mitchell, did you want to add to that?
I concur with everything. I will also say I think the quality of the applications is really improving. I think there were a lot of really strong candidates to choose from. As noted, Richard and I did ask to go back out for additional position applicants because I don't think the awareness was there, because once the awareness was raised, we got a lot of great applications. So anyway, I think the process was efficient and effective, so we are pleased to present the slate.
And I guess I just finally want to again thank the staff. As we've gone through this process, the staff has done an amazing job in helping compile the information and analyzing it for us. And so we've learned a few lessons from the first rounds. So now you can see we do have that demographic information and other types of information for the board to also review for the appointments. So thank you very much to the staff for your hard work. Thank you.
Thank you, Richard and Elizabeth, for also serving in that capacity. Recognizing that there are some members who are not returning, just tremendous appreciation for everyone who has sat in this advisory committee capacity. Very much appreciate everyone's contributions. And with that, I will actually call for a motion to approve the recommended advisory committee membership.
I'll move it, Madam Secretary. I also just want to add my thanks to the subcommittee who worked on this. I'm glad to hear it's gotten more efficient, and clearly when we call for nominations, that's getting more robust, so that's all good. I also just really wanted to appreciate the demographic data. I know we talked about that the last time go around, and I specifically want to acknowledge how many rural counties are represented in this demographic. That is not often the case. And so I don't know how we got there, Megan, but let me just do a shout out for the fact that that is a really good representation of our major urban centers, but also our rural centers, which are super important. So with that, I'll move it and appreciate the subcommittee's work.
Thank you. Is there a second?
Second.
We will open it up for public comment.
We'll now take public comment on this item. Please step to the podium or raise your hand virtually. Looking to the podium, go ahead.
Beth Capel for Health Access, pleased to support this motion in this slate, not only because you have our executive director and a number of our board members, but also because we have appreciated the broad participation in the stakeholder process, the advisory committee process, and want to take particular note that hospitals, physicians, medical groups, purchasers, payers have really all contributed to a very good discussion, and that it's been provided important broad oversight and was what we envisioned when we thought about an advisory committee that was broadly representative to accompany this board, which is made up of those of you who are representing it are not subject to the targets. So we very much appreciate this slate and look forward to working with them.
Thank you. Looking virtually, seeing no hands raised. Give it a moment. Looking in the room, seeing no one at the podium. That concludes public comment on this item. We will now move for a roll call vote. Dr. Sandra Hernandez?
Aye.
Secretary Kim Johnson?
Aye.
Richard Kronick?
Aye.
Ian Lewis?
Aye.
Elizabeth Mitchell?
Aye.
Dr. Richard Pan?
Aye.
That's 6 in favor. The motion passes.
Thank you, and congratulations to our new advisory committee members and those who are staying on. Appreciation to you all in serving in this capacity, and we look forward to hearing your input as we go forward. With that, we are going to take a lunch break, and we will reconvene at 12:30. Thank you. Welcome back. If we can please take roll.
Good afternoon. Dr. Sandra Hernandez?
Here.
Secretary Kim Johnson?
Here.
Richard Kronick?
Here.
Ian Lewis?
Here.
Elizabeth Mitchell?
Here.
Dr. Richard Pan?
Present.
Don Molds? We have all present.
Thank you. We are going to move to item 5A, which is an overview of HR 1 and the federal reconciliation, also referenced as President Trump's big, beautiful bill. I will let the audience know that myself, Director Boss, Director Altman, and Director Troya recently taped an overview of the provisions as they relate to Medi-Cal covered California and CalFresh. That is accessible online if you also want to get an overview of some of the changes. But want to note, for us here in California, we don't consider it a big, beautiful bill, and in fact see some really significant reductions estimated at well over $30 billion and over 3.4 million Californians impacted. So not only from individuals losing access to health care, both those on Medi-Cal and those on the exchange marketplace and covered Cal, loss of access to food and nutrition supports through CalFresh, and also the infrastructure in terms of overall payments to hospitals and others. So really important, and just maybe also appreciative of those who worked to help ensure that members of Congress understood what those impacts would be. But here we are with the president having signed and enacted the bill on July 4th of this month. So appreciate the team in providing an overview. We absolutely have our work cut out for us, both in terms of what we can mitigate, and that'll certainly be our opportunity as we've made tremendous progress in California in terms of building a healthy California for all. So with that intro, I will turn it over to you, Vishal, for the overview.
Thank you, Secretary Johnson. I'll be sharing a general overview of the timeline of changes under H.R. 1. So first, I want to focus on the key impacts for California. As most people are aware, H.R. 1 makes significant changes to the Medi-Cal program and imposes new burdens on beneficiaries, states, and healthcare providers. Many of the provisions are designed to undermine the Medicaid expansion population, in which, under the Affordable Care Act, Medicaid benefits were expanded to include low-income adults without children. The Department of Health Care Services estimates that up to 3.4 million of Medi-Cal's approximately 15 million beneficiaries are at risk of losing health coverage, with approximately 3 million people directly impacted by the new work requirements and its accompanying administrative paperwork burdens. Additionally, DHCS estimates that another 400,000 beneficiaries will lose eligibility due to more frequent eligibility redeterminations and the burden it will pose on low-income individuals and families. With these and other changes, as the Secretary mentioned, the department estimates that over $300 billion in federal funding is at risk. Moving on to covered California, the new law also negatively impacts hundreds of thousands of Californians in being able to access affordable health coverage and care through Covered California. Covered California estimates approximately 660,000 Californians will lose access to marketplace coverage due to the impacts of H.R. 1, as well as failure to extend enhanced premium subsidies for approximately 400,000 enrollees, which end in December 2025. And other recent regulatory changes that make it harder for people to enroll through a program integrity rule that was rolled out. With these changes, all of Covered California's nearly 2 million consumers will see significantly higher costs beginning in 2026. And taking us to Medicare, for the Medicare program, the law terminates eligibility for many of California's current and future immigrant senior citizens, many of whom have worked and paid Medicare taxes for decades. Next slide. Now I'll focus on some of the key provisions that affect Medicaid. The implementation years of key Medicaid changes include, in 2025, the restriction on how states can raise revenue to support their share of the Medicaid program by first revising state-directed payment regulations to cap payment rates at specified levels, depending on whether a state expanded Medicaid, such as in California, prohibiting states from establishing new provider taxes or increasing rates of existing taxes, and revising conditions under which states may receive waivers for non-uniform provider taxes used to generate federal matching funds. In 2026, H.R. 1 reduces funding for emergency Medicaid services provided to individuals who otherwise would qualify for Medicaid, but for their immigration status. The law also eliminates Medicaid/CHIP eligibility, the Children's Health Insurance Program, for many lawfully present individuals and creates a $50 billion rural health transformation program. In 2027, Medicaid eligibility for most adults will be conditioned upon working, with strict verification requirements, as well as the requirement for states to conduct eligibility redeterminations at least every 6 months. In addition, depending on whether an individual qualifies under expanded or traditional Medicaid, retroactive coverage is limited to 1 or 2 months prior to application. 2027 is also the year in which provider tax structural changes begin to phase in, and over several years, the provider tax is ultimately capped to 3.5% of net patient revenue. In 2028, H.R. 1 imposes cost sharing of up to $35 for certain services for the Medicaid expansion population under a certain FPL, or federal poverty level. 2028 is also the start date for state-directed payment structural changes. And taking us to the next slide for key changes to the Affordable Care Act. The implementation years for key ACA changes include in 2026, increased costs to consumers due to not extending the enhanced marketplace premium subsidies, which were enacted under the Biden administration's American Recovery Act, or ARPA, excuse me, as well as removing costs are also increased to consumers, but through removing repayment limits on advanced premium tax credits, and requiring individuals to repay in full any excess premium tax credit at tax time if they underestimated their income at application. In 2027, the law eliminates subsidized market coverage for most lawfully present individuals, including refugees, asylees, and people with temporary protected status. And in 2028, we'll see the elimination of automatic renewals of coverage and the establishment of pre-enrollment eligibility verification through new paperwork requirements prior to subsidized coverage. So what that in essence means is that there's no longer an automatic renewal, and individuals will have to verify information before their subsidized coverage is effectuated. And then taking us to Medicare changes. The implementation years for Medicare changes include in 2026 an increase to the Medicare physician fee schedule by 2.5% for 1 year. There's also other changes related to the federal government's ability to negotiate drugs. There's a decrease in the number of orphan drugs eligible for price negotiation under Medicare. In 2027, Medicare eligibility is terminated for most lawfully present individuals, including refugees, asylees, and people with temporary protected status. So these changes are similar to the changes that affect the Medicaid and ACA populations in H.R. 1. This termination of benefits applies to individuals already receiving Medicare as well as future enrollees. Next slide. So I'll take us to some considerations for spending targets. As a reminder, OCA will report and enforce targets by market. Reporting by market allows for OCA to evaluate the impact of the following on spending performance. This includes population characteristics of each market, cost drivers unique to each market, different policy levers and tools in each market for lowering cost growth, and state and federal policy decisions impacting spending trends. Next slide, please. As you know, the board may periodically update spending targets so that new information can inform potential changes. H.R. 1 will impact healthcare entities differently depending on a range of factors, including payer mix. Increasing target values across the board could result in higher costs for all commercial market consumers, undermining the goal that healthcare spending should not grow faster than household income. Now and through 2026, OCA staff will present for discussion proposals on spending target enforcement, including enforcement considerations for exceeding the target. Through this process, OCA may consider changes in state and federal policy affecting spending. Now I'll turn it back over to the chair for discussion.
Thank you, Vishal. And I just want to, for the public and all of those tuning in to understand, well, Vishal provided that overview on the dates, the implementation dates. The work to actually implement, in many cases, has to begin much sooner. We are awaiting federal guidance in most cases for the additional detail that it will take. And as I referenced, because healthcare and the safety net are obviously related, right? There are additional reductions, both in terms of immigrant populations' access to CalFresh or food supports, as well as the complete elimination of nutrition education. And also some very significant changes in the cost sharing for California with CalFresh. That's typically been a fully federally funded benefit to all Californians and all of those across the country. So just adding that on. Let me turn it to board members for any comments, questions that we have, especially as it relates to consideration for spending targets. Richard, please.
Thank you, and appreciate the presentation. Actually, a question which isn't directly related to California, but on the Medicare side, although I understand this is perhaps an indirect effect, under federal law, there's sequestration when the budget deficit goes up, and clearly the CBO's indicated there's a massive increase in our federal debt related to the OBB, under projections. Can you, I don't know whether you're able to speak to the cuts in Medicare that will happen due to sequestration, due to existing federal law, because of the increased federal debt that's part of this particular bill.
Yeah, we've heard about that as well, that could trigger sequestration. In the past, the Congress has always kind of delayed that from happening, but we'll monitor and we'll see if there's any information about that. We could report it back to the board.
Okay, so one of the thoughts as we're looking at this particular legislation and perhaps any subsequent legislation coming out of Congress is that as we're trying to do cost targets, you can imagine, we sort of think, in our work, we're saying, okay, we have our Medicaid bucket, we have our Medi-Cal bucket, we have our Medicare bucket, we have a commercial bucket, but there's also the uninsured bucket. All right, so people are going to generally fall into one of those four, right? I mean, broadly. And so I think it's going to be important to monitor how many people are in each of these buckets, right? Because we're projecting there's going to be a lot more uninsured. In fact, the paper you presented at the beginning of this meeting talks about that when there's a higher rate of uninsured, spending goes, the spending goes up, the expense goes up. So that's certainly going to impact our ability as I think about each of our entities who we are establishing cost targets, hospitals, others, et cetera. The fact that we're going to, certainly on the provider side, eventually, someone's probably going to end up seeing the person who's uninsured. They're maybe sicker and other more expensive. I guess we do need to track that, right? And so, and I'm just thinking, for example, and I brought up the Medicare part. Well, one of the factors we're putting in is a commercial to Medicare ratio. Well, Medicare is going to be set by the CMS, so it's not that the hospital or other entities are going to negotiate with Medicare for a better rate because their uninsured number of patients has gone up. They're going to turn to commercial because that's who they can negotiate with, right? I mean, I guess they could lobby the state for higher Medicaid rates, but given the federal match going down, I think that's not going to be particularly fruitful. So I think we need to look at all these dynamics, right, and see how that it's going to impact the ability of all the various entities we are overseeing as we're saying cost targets and their ability to respond, right, to this. Collecting, figuring out how we're going to collect this data. I mean, certainly we're collecting a lot of data now, but how, as we're looking at the data that we're collecting on spending and costs and so forth, we should be looking at with a lens of being able to say, well, what's the impact of these federal changes on what's happening to each of these institutions? After all, it is, actually changes in federal and state law are one of the factors that need to be taken into account in our cost target setting and also in our response. And we're going to talk a little later about what happens when someone exceeds a target as well. So we're going to need to have that kind of data to know how to respond. And of course, we need to think about in aggregate, right? As we're looking at overall healthcare spending in the state, how these actions at the federal government actually is going to impact affordability for people in each of the buckets, as well as, of course, frankly, including the people who are uninsured.
Thanks. I think it's important that we acknowledge also that HR 1 is being implemented in a context where federal policies that are very specifically targeting people of color and immigrant communities are making it dangerous for people to go to work and therefore jeopardizing their employment-based health insurance. And also that these, especially immigration actions, are targeting health facilities or neighborhoods around health facilities. I can attest that there are people who are not getting the care they need right now because of fear, and that affects not just publicly supported plans, but also commercial employer-based plans. And so I add to the chorus, I think probably the consensus that we need to put as fine a pencil to what the actual real-world impacts are for policymakers in the future, but to include all that turmoil that's happening outside HR 1 as well. And then secondly, obviously with the pending discussion about enforcement, there's a lot of talk about using HR 1 and other federal policies as an excuse to raise prices on commercial payers. And I need to say, like I've said, there's no more blood to be squeezed from this stone, but allowing providers to increase rates at will to offset or even perhaps more than recoup the money that they're losing in other lines of business amounts essentially to an unlegislated tax increase. And if we're going to have a conversation about budgets for providers and making them whole for losses, that really is a question of taxation. That's something that the legislature needs to grapple with. I, for one, don't think OCA should ease off on following through on the targets that we've set. In fact, to the contrary, HR 1 and everything, all this fallout is all the more reason that we need to really ensure that the vision of OCA and its target setting is made real and quickly.
Yeah, I appreciate both of those comments. And I think it's also worth noting that this was a summary of HR 1. There are also CMS regulations that are coming down that have a significant impact on our primary care capacity in the state. If it changes the way our FQHCs can approach the care delivery that they have historically done. So on this, how do we keep track of all of these implications? It's important to also look at the regulatory environment and not just HR 1, as bad as HR 1 is, and we'll hear more about that, I'm sure, in public testimony and as the agencies get more of a sense of directives. The other point worth making, when we talk about the impact on the state, there's also going to be enormous impact on counties because counties run county hospitals. counties do eligibility work, et cetera. So just important for us to not lose sight of the downward sort of domino effects of HR1 on our infrastructure in the state. And then to Ian's point, California has done an amazing job at recognizing everybody who lives here as being part of the fabric of our society and certainly warranting health care. And much of these actions on immigration per se and immigration policy very much overlap with our health care goals. And it's really important, I think, for us as a public sector and civil society to acknowledge that the progress and the values that California has stood up for, we need to continue to do as we figure out how to work our way through HR1 regulations and immigration policy.
Thank you. It is hard, I think, to overstate the cruelty and stupidity of HR1 and other actions coming out of Washington. Having said that, HR1 should make it easier, not harder, for California entities to make the 3.5% cost growth target. To Ian's point, it may be that it'll make it harder to the extent that we're looking at payer-specific targets. It may make it harder to meet the commercial target to the extent that hospitals say, oh, we have to get more money from commercial payers because we're getting less money from Medi-Cal. But on the overall, to the extent that HR1 is taking money out of the healthcare system, that makes it easier to hit 3.5%. It doesn't become an excuse to go above 3.5%. And I think, Richard, to your earlier point, yes, it's true that when more people are uninsured, they will eventually need some care that they that will be expensive, that could have been avoided had they had insurance. But the main thing about having more people uninsured is overall health spending goes down. I mean, the point of insurance is it improves access to care and it increases the use of healthcare services. So, the very sad truth is if we have more people uninsured, it may hit commercial rates to the extent that hospitals are successful in cost shifting to the commercial side, and say, oh, we need to recover more money for bad debt and free care. But overall, it results in lower spending. So, I mean, this is an abomination, but not, I think, a rationale for exceeding the 3.5% target.
Not seeing any other comments from the board, we will open it up for public comment.
We'll now take public comment on this agenda item. Please limit your comments to this item and to 2 minutes so we can hear from as many folks as possible. Looking virtually, if you'd like to make a comment, please raise your hand. Seeing no hands raised at this time and noting we have about 90 virtual attendees looking to the podium.
Beth Capel for Health Access. We began part of this conversation earlier today by noting that many of us have worked to reduce the number of uninsured, some of us for many decades now, and that the combination of HR1 and the recent state budget and likely future state budgets have turned back the progress we have made toward universal coverage. In our view, none of the cuts justify exempting providers or plans from the cost growth targets or the enforcement of them. All of it goes to what this board has already begun, which is a thoughtful and careful discussion of what the impacts are and analysis of that. We do recognize that there are reductions in Medicaid provider funding, such as the elimination of the MCO and other reductions. But the overwhelming impact is on the uninsured and the increase in the uninsured. As I said earlier, and I'll say again, in effect, HR1 repeals half the ACA Medicaid expansion. The state budget repeals half of the Health for All expansion. And both together limit coverage of lawful immigrants, something I have not seen in the last 40 years. The work requirements that are imposed by HR1 we think we can mitigate the impacts by using the information that EDD tax branch has on the earnings of California workers that are affected by the work requirements. And that's something we look forward to working with this administration and this legislature on. We will reiterate that the uninsured do not get the care they need. They live sicker. This is one of our refrains that I hoped I would never have to say aloud again. The uninsured live sicker, die younger, and are one emergency away from bankruptcy. That's why healthcare spending goes down when there are more uninsured. We recognize that pre-ACA in some counties, particularly those in the Bay Area, and for a few years, my way LA, the uninsured got more comprehensive care from county hospitals, county health systems, and community clinics, but never as much as those of us who are fully insured got. In terms of the cost growth targets, cost shifting to commercial coverage is only justified if the provider is providing care to the uninsured. Pre-ACA charity care provided without expectation of payment was 2% of revenue. Now it's 1% of revenue. Those are well-established statistics. Cost shifting to commercial coverage might be justified if it was actually the result of providing care. If it's simply replacing revenue, it's not. That's been our view, and we will continue to work with you on that. Thank you.
Thank you. Looking virtually, seeing no hands raised, back to the podium.
Hi, Ben Johnson from the California Hospital Association. First, just appreciate the overview of the major federal policy changes enacted in the reconciliation bill. The hospital field remains in shock with the passage of the largest federal healthcare cuts in certainly recent, if not all, of American history. We do encourage continued focus, as Board Member Pan noted, on the dire consequences from the OBBBA. And while the bill cut healthcare spending by maybe nearly $1 trillion nationally, for hospitals alone in California, we anticipate $66 billion in financial losses due to restricting the financing mechanisms that hospitals have long relied on to close the shortfall in Medi-Cal payments, as well as automatic cuts in Medicare that are coming. And on top of this, with the nearly 2 million or more Californians expected to lose coverage as a result of the various changes. It'll make them sicker, increase reliance on already overcrowded emergency rooms, and vastly increase uncompensated care at hospitals. So totally agree with prior speaker that this undoes much of the incredible progress that's been achieved over the last decade in California, particularly for providing coverage for those with low incomes. Do want to urge this office to improve and take steps to encourage the resiliency of California's healthcare system. OCA's targets do risk exacerbating several of the impacts the negative impacts of the federal legislation, insofar as if revenue cannot be somewhat sustained, cuts in services, jobs, full hospital closures are essentially guaranteed, given that half of hospitals already have negative operating margins and many are sustainably and chronically operating in the red. So urge the continued discussion and consideration of this important topic. Thank you.
Thank you. Continuing public comment, looking virtually, seeing we have about 90 virtual attendees, no hands raised, seeing no one at the podium. That concludes public comment on this item.
Thank you very much, and we will obviously continue the focused conversations on this front as implementation moves forward. We are going to move to item 5C, discussion of data submission enforcement. Vishal, Deputy Director, and CJ Howard, Assistant Deputy Director, will take us through this item.
Good afternoon. My name is CJ Howard, the Assistant Deputy Director over the Healthcare Spending Targets Program, or branch. We'll now discuss data submission enforcement, including the statutory requirements, a potential penalty structure and process, and timeline for next steps. And that next slide. This slide shows the roles for the board and the office to enforce data submission requirements. The board approves the scope and range of administrative penalties and the penalty justification factors for assessing penalties. The board also reviews and provides input on administrative penalties. This is done to inform any adjustments to the scope and range of administrative penalties and the penalty justification for assessing penalties. The office has the authority to assess administrative penalties when healthcare entities fail to comply with this chapter of the statute, specifically by willfully failing to report complete and accurate data, knowingly failing to provide required information, and knowingly falsifying required information. The office also has authority to adopt regulations to implement this piece of the statute. Go to the next slide. This slide shares information about recent and upcoming data reporting years. So for the data that were reported in 2024, OCA received all files from the 17 required submitters. On average, plans resubmitted each file about 2 times before OCA accepted all of the plan's files as complete and accurate. OCA provided technical assistance to all 17 entities. For timing on this, 13 plans had submitted all of the files by October 1st, 16 plans by November 1st, and all the plans, the last one, by middle of December. So while we had compliance with data submission in our first year, we are also mindful that we need to build for future when spending target performance, compliance, and reporting are more at issue. So for the data that will be reported in 2025, OCA will be requiring 2 new files, the alternative payment models and primary care files. Medi-Cal managed care organizations will submit APM and primary care files, and OCA will continue to use total medical expense data from DHCS for managed care organization reporting. Combined with the addition of MCO submissions, plans will submit data by licensed entity, which will expand the number of submitters from 17 to 51. So for 2024 submission, the 2024 submission was at the parent level, not the plan level. So that's part of also what's explaining the increase in submitters. For the data that will be reported in 2026, OCA may add a behavioral health file to the data submission, and other requirements may be added or existing requirements may be amended based on lessons learned from the 2025 data submission. Go to the next slide. This slide covers information that the board would need to approve. So the scope and range of penalties includes the penalty amounts and the penalty structure, which could be a flat fee, a per day fee, a per member fee, or a mix and match approach. Penalty justification factors guide OCA in determining which board-approved penalty amounts are assessed, and the following factors are outlined in statute: the nature, number, and gravity of the offenses, the fiscal condition of the healthcare entity, including revenues, reserves, profits, assets of the entity, as well as any affiliates, subsidiaries, or other entities that control, govern, or are financially responsible for the entity or are subject to the control, governance, or financial control of the entity, and the market impact of the entity. Other factors can be considered, such as the entity's cooperation and active communication with the office. So next slide is just discussing some of the considerations for the penalty structure. Those include a view that the penalty needs to be reasonable, provide an incentive to submit data timely, and deter entities from not submitting or withholding data to evade spending target enforcement. OCA is unable to measure total healthcare expenditures or total medical expenditures for that matter, or enforce the data against entities that fail or refuse to submit data. If an entity fails to submit data, it may also impact downstream reporting of spending for other healthcare entities, such as provider organizations that are measured based on attribution of total medical expenses. In the following illustrative scenarios for discussion today, we focus on a penalty structure for submitters who first submit untimely data and second, ultimately fail to submit data. Under existing process, once data is submitted, submitters have 5 days upon notification to remediate errors with the office. This penalty structure would also apply for the submission of inaccurate or incomplete data. Next slide. Or this slide, rather. OCA suggests a 2-tiered penalty structure. The first tier is a flat penalty for untimely data submission. This flat penalty encourages timely data submission while not being overly punitive. The penalty would be assessed if the data are not submitted after the submission date or after the expiration of any approved extensions. And a potential flat penalty amount could be $10,000. The second tier is a per member penalty for failure to submit data. The penalty is intended to prevent an entity from evading spending target enforcement by willfully refusing to submit data. The per member penalty would be larger than the flat penalty and assessed when an entity fails to submit data. OCA would use progressive enforcement steps to allow multiple opportunities for remediation before assessing the penalty, and a potential per member penalty amount could be $5 per member. If we go to the next slide, I'll go through kind of what this process could look like for data submission and enforcement. So first, the data are due to the office by September 1st. Next, we've included 2 optional extensions that can be required by or requested by the submitter. Extension 1 would be a 15-day extension requested by the entity by the submission deadline. And the office would require regular check-ins with the office. For example, email status updates every several days, including the barriers that the entity is experiencing, current projected submission date, progress towards completion, and any need for technical assistance from the office. The second extension would be an additional 15 days and could be requested by the entity prior to the first extension ending, and would be contingent upon the entity complying with the requirements of the first extension period. OCA would require regular check-ins during this period with the office, and the same requirements as the first extension would apply, so the regular updates. Here I want to note that the ultimate goal is to obtain the data so that we can accurately report on spending growth and performance against the cost targets. So we have 2 extensions which allow the submitters to submit the data and avoid further enforcement or penalties. But if that hasn't happened, go to the next slide. We would propose imposing an untimely data submission penalty. If the data has not been submitted upon the conclusion of one or both extensions, or if the extension periods are not requested, the submitters would be subject to a flat untimely data submission penalty. Submitters would then have until November 1 to submit or correct data, or be subject to progressive enforcement steps, which could result in a failure to submit data penalty. If data is not submitted by November 1st, progressive enforcement would begin on November 1st with a notice that the submitter has failed to submit data. The office would provide technical assistance and allow up to 30 days for the submitter to submit the data. We've included an optional step where the office could compel public testimony. And last on this slide, if data is not submitted at the end of the 30 days, the submitter would provide a data submission plan to the office indicating the actions they will take to submit their data no later than December 31st or by a date agreed upon by the office. I want to note here that while the submitters would face an untimely data submission penalty at this point, they can still submit data to avoid progressing to the next tier of enforcement, which I'll outline on the next slide. So this slide details the second tier of the suggested 2-tiered penalty structure, the failure to submit data penalty. If the data is not submitted by December 31st or the agreed upon date, the entity would be subject to a per member failure to submit data penalty in addition to the untimely data submission penalty. For data submitters that repeatedly fail to submit data each year, the failure to submit data penalty amount would increase. OCA will make public all penalties once formally assessed, and OCA could pursue other legal remedies in addition to the penalties. Next slide. So this slide shows what this suggested process would look like for a submitter that asked for both extensions, giving them all of September to submit the data. If they do not submit the data by October 1st, they receive a notice that a flat penalty may be assessed, and they are given steps to avoid further action by November 1. And we can see that the untimely data submission penalty, as presented here, is the only financial penalty until the end of December. On November 1, if the entity has not yet submitted data, The entity receives the notice that progressive enforcement has begun. At this time, they're given an additional 30 days to complete the data submission process, and the office provides additional TA or technical assistance. The optional step of public testimony could take place at this time as well. If the entity is not submitted by December 1, the entity receives a notice that they must complete a data submission plan, and the data must be submitted by December 31st or by a mutually agreed upon date. And by January 1, we have two possible outcomes. Outcome 1 is that the entity has submitted and OCA has accepted their files, and the entity is only assessed an untimely data submission penalty for not submitting by October 1, or their two extensions. And then outcome B is the entity has not submitted or their files have not been accepted by OCA, and the entity is assessed both the untimely data submission penalty and the failure to submit data penalty. This next slide just shows a scenario where an entity did not request the extensions but still failed to submit the data by the September 1 deadline. Here the entity would face an untimely data submission penalty on September 1, and the rest of the timeline is the same as above. Again, our ultimate goal is to obtain the data so that we can accurately report on spending growth and performance against the cost targets. Next slide. Here we see examples of what penalty amounts might look like for different sizes of data submitters by covered lives, if they faced an untimely data submission penalty and if they faced a failure to submit penalty. The $10,000 is the amount listed in the example for the untimely data submission penalty. This amount is similar to data submission penalties from other programs that we've surveyed. The amount for the failure to submit penalty is significantly higher to reflect the impact of not submitting data on OCA's ability to accurately report on statewide spending growth and OCA's ability to ensure compliance with spending targets. This slide is merely an illustrative example and is not a formal recommendation. Next slide. Which is great because I'm getting tired of speaking right now. I don't talk this much anymore. Does the board have any initial feedback on the penalty structure, scope, and range, specifically the two-tiered penalty structure, the timing of potential penalties, the untimely data submission penalty amount, the failure to submit complete and accurate data penalty amount?
Thank you. I think this is very thoughtful and likely workable. I would just note that for the hospital transparency reporting, the federal rules, I think for the first year or so where penalties were nominal, they saw almost no compliance, which is the cost of doing business, so it was promptly ignored. They significantly increased the penalty, and there's some improvement. So I guess I would just encourage us to make sure that whatever the penalty is, it's meaningful enough that it will get the attention. I would also consider tracking. There are new regulatory approaches to enforcement at the federal level on data reporting and transparency that may help. So just tracking those as those are considered may align with these goals.
Thank you for the presentation. I appreciate the thoughtfulness of what's being proposed. First of all, one question is that the standards for the data submission that's due on September 1st, when are those sent out to the entities that need to submit? How much lead time do they have prior to the September 1st deadline?
Yeah, so those are promulgated by way of the data submission guide.
Right.
I believe that those data submission guide regulations were promulgated in March or April, and they're usually first socialized several months before that. So at least 6 months before September 1st, if not more.
Right. So in other words, they'd have approximately 6 months or more, 6+ months. The deadline shows up, and I'm just trying. And again, I appreciate, and we want to encourage people. Ultimately, we want the data. I mean, the penalty is but we prefer to have the data than the penalty. But I guess part of what I'm also thinking is that with 6 months lead time, what's holding you up that you can turn things around in 15 days or even 30 days? So while I appreciate and I have no opposition to the extensions, What kind of scenario do you think is happening where where a plan is unable and is able that spent 6 months and was still unable to turn in the data, that they're going to do something different in the next 15 to 30 days that's going to get them to get the data in the form that we wanted in?
Well, as presented, we only have a sample size of 1 year where we've done this in 2024.
Sure.
The vast majority, I don't know how many plans off the top of my head had submitted by September 1. Again, but we had 80-ish% compliance by the end of October. So why the extra 30 days? I think it was just really working through those last final checks.
Okay. All right. Well, and certainly I think that if the plan's in good faith, and I also want to acknowledge the fact that every single entity did submit, by the end of the year, right, in the first year. That's a good sign. I mean, we're not, again, the goal is not to penalize people as much as to be sure we get the data. I guess the other question I have is when it comes to, so they got the 2 extensions, now they got the notice of untimely submission. You then give them a month for you after you send a notice of failure, submit data, and then the following month you ask them to submit a data submission plan. And I don't know how many days you're going to give them to turn in this plan, but shouldn't you just go ahead and do that on November 1st and then say that you need to implement it by December 1st? Because otherwise you're asking for the plan on December 1st, but you want the data by December 31st. And I don't know when they're supposed to submit this data submission plan. So you might as well ask for the data submission. Hey, like if you haven't, you're already late. If you haven't done it, by the way, you're going to get an untimely submission with that big penalty. Maybe you should working on your data submission plan. In other words, your explanation of why you still haven't gotten the data to us right at the outset instead of waiting till December 1st, because they're going to need some time to put that together, I think, if it's a serious one, right? So, okay, so just a thought there. And then the other thing that I'm also, and again, hope we never end up going here. So this, again, the purpose is not to extract money, but I think as Board Member Mitchell said, there's some of it's about the penalty has to be enough that it's not just the cost of doing business, because the problem for us is that we don't have the data. It doesn't just affect our ability to manage that particular plan, depending on how big it is. It also, because we have to aggregate all this. Now we're missing a piece or two, right, of the puzzle, and so that makes it harder for us to get accurate information, right, when we have missing pieces, right? So that actually inhibits our ability, or this office's ability, to do the things it needs to do when a plan does not. So to me, again, the amount, certainly want to look at. I want to think about what percentage it is of their annual revenue for a typical plan of each size. That it's something that's at least not nominal when it comes to, and you said per member per month, per member. And then the other thing is that, and again, I hope we never have to go here, that we wouldn't have an entity that just refuses to turn in data year after year. But I would seriously say that, there's a penalty for 1 year, and if you miss 2 years in a row, we double it. If you miss it the 3rd year, it's like 4 times. If you miss it the 4th year, it's 8 times. It goes up exponentially, and so. I mean, at that point, this is like willful uncooperation. So hopefully nobody would want to go there. Certainly, there's no indication anyone's going there, given the fact that every single plan submitted something by the end of the year, the first year. So, but I also think that we need to have that in place, not because before anyone goes there, because we're not trying to pick on anyone. After all, there's no one I'm thinking about right now, but that a plan that repeatedly, year after year, does not submit their data, at that point, you can only think it's willful. And there should be some serious penalties about doing business in the state of California if you're really going to be that uncooperative for that many years.
At the $5 per member level, that intuitively that seems to me substantial enough that the deterrent effect is there. So this might be theoretical, but when I think about a situation where a plan is refusing to provide the data, it seems intuitive that one would want a penalty that tolls, increasingly over time, not even year to year, but like month to month, week to week, or what have you. I think that's the approach the FPPC uses, or the Franchise Tax Board, or others. Did you put thought into that kind of structure, and if so, why did you settle on a one-off penalty?
Yeah, part of it was simplicity, and part of it's and just making sure that people realize that there is a firm line in the sand, and also balancing it with sort of the operational need of the program. That really, in order for us to do all of our reporting and aggregate all of our data, and then a part of our process in the first year was to do the payer level previews, and then ultimately that'll expand to provider organization previews. And so really, like, whether it's after you get past, let's just say about early to mid-October for us, like whether, by that point, if we don't have the data by mid-October, a lot of those things are already going to be jeopardized. If we don't have it by the end of January, now you're really getting into our ability to enforce and to timely go through the discussions that we're going to have in the subsequent months around enforcement, and then make sure that we're able to even just report at the end of the year. And so I think it was just kind of balancing out, like, thinking through it also, like, when do we really need to have the data? And there's sort of two cliffs here, and when does that unfold? So I think that's why and so for those reasons, both simplicity, but also sort of the operational considerations of what happens if we don't have the data, and does the harm to us and the ability for us to perform our functions ratchet up daily? Not necessarily, but there are a couple cliffs in the reporting processes that we have to generate an annual report and ultimately get through our future enforcement processes.
Thanks. Thanks for the thoughtful presentation. I had the same question as Ian, which is kind of first thought would be, rather than a one-time penalty, to have it every month. To your response, CJ, maybe it makes sense to have two penalties, one for the earlier October or December 1st need, and then one for the later one. But it still would make sense, I think, to me, to have an ongoing, or at least a third. What if you have a penalty that just ends? Then there's no financial incentive, at least, for submitting, and you want to, I think, keep some incentive there. It's wonderful to hear that in the first year this was largely not problematic. But my second question is about kind of incomplete, or data that doesn't pass the tests that you have for it. And I would imagine, especially if there are penalties in place, and if somehow in subsequent years it's not as good as the first year, that some plan might just submit basically a blank file and say, well, I've submitted it, and then you say, well, no, this isn't good enough. But what your thoughts are about differentiating that from the plan that submits not a blank file. They've made a good faith effort, but it's sort of not good enough, and you go back to them and say, well, it has these problems, please fix it. In that situation, I assume you would not be imposing a penalty, at least not right away, but then kind of whether this is a gray line problem, or you think sort of pretty clear about to be able to differentiate the almost blank file from the good faith effort, and how you might deal with that.
Yeah, I mean, there is, in the data submission guide, there is the 5-day carve out where once the data is submitted to us, there is sort of a 5-day cure period. I think that would all be integrated into this. So, I mean, some of the issues that we faced in the first go at this was, just making sure that the bottom line numbers ticked and tied, and especially on the attributed file, that there were sometimes mismatches, and so we would work with the entity, and they would quickly turn around and correct discrepancies that we would be able to encounter.
And how quickly do you conduct the review process to figure out that there are either problems or it's fine? How long does that take?
I don't know on a case-by-case basis, but it's like, I know that our automated checks that we have are done in an automated, like, relatively quickly fashion. I mean, our ability to go through our checks takes a business day or two, I believe, but I could confirm that for you all next time.
Oh, yeah, I appreciate the thoughtfulness. I think the two-tiered system makes sense. For folks that do not submit, you have here in blue that an option would be to do public testimony. Actually, I would want to hear from entities in this forum at that time why they have not submitted. I think penalties, financial penalties, have motivation. I think there's a whole other motivation that comes with public transparency. And so I really like that notion, and whether you do it in early December as a way to get an understanding of why we need the data, how we're going to analyze it, why not submitting it is not acceptable. I actually think that's a really important component to add to this. And then for the entity, which I can't imagine that year after year doesn't submit, I do think we should think about what else we would do besides financial penalties. I have no idea what that would entail, but we should give some thought to it.
To Board Member Hernandez and Cronix's points about kind of what happens after penalties. On an earlier slide, we did indicate that we could pursue other legal remedies or legal action. So it doesn't end with penalties. Like, we reserve the right to take legal action.
Like, what do you have in mind there, Michelle? What legal action?
You know, they wouldn't be following, they'd be violating state law. So, you know, we would work with our legal would work with the Attorney General's office to pursue action.
When it comes to having them come to a public hearing or whatever we're going to call this, I don't know whether we have the authority to compel them to come if they don't want to. Again, hopefully no one would actually feel like that they could do that. That would be a good idea. Let's put it that way. But I guess that's the question: is that we can have a public hearing, and I guess if they don't show up, we can still lambast them for not showing up. But I'm not sure. Can we compel them to come?
Yeah, we have subpoena authority.
Okay, so we can compel them to come. Okay, even if they sat silently there. Okay, all right. All right. Well, I mean, again, it would be a problem. I think it'd be problematic for the entity to do that, but yeah. Okay.
Yeah, so we actually have one more slide. We've already touched on some of these issues, so some of it there may be overlap, but if we can advance. So this is, does the board just have any feedback on the timing and duration of extensions or the progressive enforcement steps? I know we've already heard some input on both, I think, extensions and enforcement steps, namely around public testimony.
You know, I think the thing, obviously, there's two things related to timing, right? Well, one is to be sure that you have OCA has the time, receives the data in a timely manner so you can do the things you need to do as the state law asks you to, and what we're supposed to provide oversight over, right? So, and you've talked a little bit about that. And then the other one is, in terms of timing, is being reasonable with the plans in terms of what we're asking them to do, that we're not being overly onerous in terms of what we're asking them to provide to us, right? And given the experience of the first time, hopefully we're striking that balance. It'd be good to hear, have we received any feedback from the plans about the kinds of data we're getting that they're saying that's problematic for them to meet the kind of deadlines we're asking?
We've had some initial discussions with plans, but I'm sure that as we progress and flesh this proposal out and take back some of the input that you all have provided, I'm sure we will.
Yeah, they generally, ask for any changes to the data submission guide that gets socialized and actually put into regulation earlier because of the system changes they need to make. So they're very sensitive to that, and we're mindful of that as well. But we do try to give them at least a minimum 6-month lead time, and we plan to kind of continue to do that as we update the data submission guide.
And I just really want to appreciate the approach the team that's taken, which is really important to us at HCI as our stakeholder relations. So we're, the team consulted with the plans ahead of time. They have a work group. There were test files, of course, that were submitted, so we're really doing a lot to work with the plans. I do want to note that, and I think folks know this, we are getting data from the commercial and Medicare plans. We've been getting the Medi-Cal data from DHCS, so we'll need to work closely, and we're committed to doing that with the Medi-Cal plans that may not already be data submitters to OCA.
Sorry. I appreciate that, and certainly, that's why I asked the question about 6 month lead time, et cetera. So, and certainly, at least at this point in time, no plan has at least felt compelled to find me and say, hey, you know what, we're being asked too much or whatever. So, not to say they won't come back later and say that, but again, I think it's about striking that balance. But of course, we need to be sure you have the data, so you can do the things that you need to do, so we can have the data to look at with all the questions we tend to ask at these board meetings. So, I think what you're proposing is reasonable. I do think that, it's again, hope we never have to go here. But anyone who's, I guess, intentionally being, saying it's a cost of business or defiant, we got to be sure it's beyond the cost of business for them to repeatedly not comply with the rule, what we're asking them, because it's not just affecting our ability to regulate that entity, it's actually affecting our ability to look at the whole picture as well, which is, of course, the charge of this office.
Yeah, we very much appreciate the board members' input about repeat offenders and the need to have a piece there. So we'll take that back.
Go to the next slide. So this slide shows the timeline for next steps on data enforcement. We'll continue discussion at the August board meeting. From August to October, we'll gather input from stakeholders. In September, we'll discuss with the advisory committee, and then we're aiming for a board vote between October and December. In January and February, we'll discuss regulations at board meetings, and we'll submit regulations to the Office of Administrative Law in March of 2026, making them effective by April. And the data submissions would be due on September 2026. This timeline aligns with the planned regulations for the data submission guide updates and other,
Great. Thank you again for the work on that item and for the feedback. And it sounds like we'll be coming back to the board for some additional feedback. And now we will open it up for public comment on this item of data submission enforcement.
We'll now open it for public comment. Please step to the podium or raise your hand. Seeing no hands raised online, I'll go to the podium.
Beth Capel, Health Access. There have been some allegations that health plans get a free pass. That has not been Health Access's experience. They have medical loss ratios, they have rate review, and now we're beginning by talking about penalties for health plans that fail to submit timely or completely. To add to the board's discussion, and there, as always, you've raised a number of good points. That annual cycle, which Dr. Pan, you noted, is at the heart of OCA's work, is part of what underpins the need for these penalties. We too support not escalating penalties for repeated failure. We also commend to further consideration discussions about data completeness and accuracy. I'm thinking here about whether it's primary care or behavioral health, which are going to be important for us, important parts of the data submission. I would also ask the board to think about one of the earlier slides we saw where the current private health insurance per member per year expenditures are about $7,600 a year. So as you think about what's a nominal penalty and what's a penalty that's sufficient, that's more than the cost of doing business, some of the amounts on this page look a little breathtaking until you start multiplying 8 million times 7,600, and there are more zeros than I can do quickly. Or probably even longhand. So I would just encourage that consideration as you think about scaling these penalties and making sure that the information is both timely and complete and accurate. And I think all those things should be considered. So we look forward to further discussion. Thank you.
Thank you. Looking virtually, seeing no hands, looking to the room, to the podium. Seeing no one at the podium, that concludes public comment on this item.
Thank you very much. And we are going to move on to the next item, item 5D. This is the spending target enforcement and timeline. Keep it right here with Vishal and CJ.
Okay, so next we're going to introduce the topic of spending target enforcement. I think this will be a long multi-month process for the board, and so we can get right into the timeline for the future discussions. So this slide shows our timeline for a discussion of spending target enforcement. We've organized the discussions around different parts of the enforcement process. This month, we're introducing the topic of spending target enforcement and focusing on assessing performance. Assessing performance means evaluating an entity's compliance with a spending growth target and taking into account a variety of enforcement considerations that inform the progressive enforcement steps. Today, we'll spend most of our time on enforcement considerations. From August to October, we'll continue the discussion of assessing performance with other topics. Then in November and December, we'll move on to technical assistance. In January and February 2026, we'll discuss public testimony. In March and April of 2026, we'll discuss performance improvement plans. In April and June, we'll discuss penalties. And last, from July through October, we'll focus on the regulations process. We can go to the next slide. The slide shows board responsibilities that are laid out in statute. The board approves the scope and range of administrative penalties and the penalty justification factors for assessing penalties. The board also reviews and provides input on performance improvement plans prior to approval via board presentations and discussions by the director. This includes periodic updates about compliance with performance improvement plans to inform any adjustment to the standards for imposing those plans. Last, the board reviews and provides input on administrative penalties to inform any adjustments to the scope and range of administrative penalties and penalty justification factors for assessing penalties. Next slide. I'm going to try to move through these next slides fairly quickly and not go through each of them verbatim, but they are listed as a reference to guide our discussions and deliberations. So this slide shows the statute language outlining enforcement considerations in the progressive enforcement process. Go to the next slide. This slide shows the statutory requirements for the office's communications with entities that exceed the target and details a couple of steps that the office must take prior to enforcement. And go to the next slide. This slide shows the statutory requirements around enforcement. Of note, the office shall provide technical assistance to all entities that exceed their spending target, and the office may also require the submission and implementation of performance improvement plans. Go to the next slide. The office also has the option of establishing a waiver of enforcement actions due to a number of factors outside the entity's due to reasonable factors outside the entity's control, investments to minimize future costly care, and other extraordinary circumstances. Next slide. Now I want to introduce an enforcement process flowchart. This is an attempt to show the various steps as outlined in statute and how an enforcement process could work. We start at the blue box on the left labeled number 1 with OCA analyzing the submitted data from entities. You can follow the arrows from there. If the entity met the target, the process is over. If the entity did not meet the target, we proceed in the process flow and send the entity a letter giving them 45 days to respond with more information. Next, OCA considers a number of enforcement considerations and provides technical assistance to all entities that exceed the target. Last on this top section, in the green diamond labeled number 6, OCA must decide whether to proceed with progressive enforcement. OCA does this based upon the submitted data and the additional data and information provided by the entity within the 45-day period. If OCA does proceed with progressive enforcement, you can see the steps, including optional public testimony, a performance improvement plan, determining whether the spending target is eventually met, and if necessary, assessing penalties. I also want to note the step in the yellow box labeled 10 that requires the board It requires a board presentation for the review and input on performance improvement plans. With that, I'll hand it over to Vishal.
So next we want to discuss the difference between some terminology. Enforcement considerations refers to factors that OCA can consider during progressive enforcement. This comes from a specific part of the statute which describes what the director shall consider during enforcement. This includes each entity's contribution to cost growth in excess of the applicable target, and any actions by the entity that have eroded or are likely to erode access, quality, equity, or workforce stability, factors that contribute to spending in excess of the applicable target, and the extent to which each entity has control over the applicable components of its cost target. Reasonable factors, shown on the right, is from a specific part of the statute which describes an optional waiver process that OCA may establish. Reasons that would allow an entity to apply for a waiver include reasonable factors outside the entity's control, such as changes in state or federal law, or anticipated costs for investments and initiatives to minimize future costly care, such as increasing access to primary and preventative services, or under extraordinary circumstances, such as an act of God or catastrophic event. So we're distinguishing between the two because we'll be focusing on enforcement considerations, which is shown on the left side of the table in the next section of slides. This slide shows information from prior presentations by the Oregon Health Authority and Massachusetts Health Policy Commission during the March 2025 board meeting. Both leaders from each of the states presented on considerations that would impact how healthcare entities within their state proceed with enforcement. I want to note that Oregon's list is not static and they have added to it in recent years. Then taking us to the next slide. So here we're looking for some feedback from the board. We have some potential considerations listed here. We have a more detailed discussion in the next section about high-cost drugs. And then we pose a question here on the slide about how should OCA distinguish between controllable overspending and external cost pressures? And just want to turn it back over to the chair to facilitate some discussion.
Yeah, Richard? So I guess I do have a question in terms of going back, and I know we're going to touch on these more in depth later on. So in the enforcement process flow, right, we start off by providing technical assistance and eventually getting to a performance improvement plan. So I guess one of the questions I do have, whether you have an answer right now or we'll get to it later at a future meeting, is that, okay, someone's over the cost target. We ask them for the reasons. They submit that, right, 45 days. We assess their performance, provide technical assistance. They follow our technical assistance. They're still, and again, actually, and what we don't have here is, okay, so now we provide technical assistance. How much time do they have to implement that? And then, but if they follow our technical assistance and they continue to be over the cost target, what's their responsibility? Because after all, we provide technical assistance and they followed it, right? And then even further, if there's a performance improvement plan and they follow the performance improvement plan and they're still over the cost target, then what, right? After all, they are following what we're asking them to do. At some point, we are essentially telling them how to run their entity, whatever it is, hospital, medical group, whatever else, health plan. So we really have to think hard about what exactly does it, we provide, what kind of, and technical assistance, what is the technical assistance, right? When we say technical assistance, what is it, right? Is it, how comprehensive is it, how, et cetera? So I think those are really going to be some really important questions to address in figuring this out. Because, I mean, it's great to say technical assistance, but what is it? How, if they follow it, and also, how we define that they followed it or not, right? How do we assess that? Then if they followed it, then they're doing what we're asking them to, then should they still be subject to penalties if the results aren't what we hope them to be, right? So, because now it's us, we're asking them to do it, not them. So, and exactly how detailed and intrusive are these technical assistance suggestions, right? So, I mean, those are going to be some really important things to try to sort out. So, I mean, I appreciate, when we talk, and we're talking about enforcement considerations, interesting changes in state and federal law. I think we had one of the most significant changes in federal law in decades that just happened. So if that's not a reason to say there's a problem, then, I don't know what you're asking, what else you want them, what kind of change in state or federal law you're asking for that to be, obviously it's about what the impact of that. But I do think, when it comes to the technical assistance and performance improvement plan, we do have to have some discussion about what it means to provide that and what it means if in terms of compliance, and if they follow that, and what's the consequences to the entity.
Thank you, Dr. Pan. Those are all great questions about technical assistance, and per our timeline, we'll have a more detailed discussion about that. Today, we just wanted to kind of focus on the overall, what we're calling enforcement considerations. And then just wanted to follow up on a comment you made about, if an entity does undergo a performance improvement plan, it would be something that they would propose the strategies, and then there would be a dialogue between the healthcare entity and the office, and then input from the board on approving that PIP. But we wouldn't be running their organization. I just want to clarify that. They would propose strategies and we would approve. Yeah.
I would just be leery of bringing performance improvement plans to the board. I'm not that I'm trying to reduce the workload here, but that strikes me as a level of granularity and potentially mission creep that I would be anxious about getting into, just for what it's worth. I mean, at a high level, if you're talking about kind of what they're structured like and answering some of these questions, fine. But boy, I mean, if you're talking about having lots of entities missing the targets, which is going to be the case, at least initially for sure, and then getting into the why on a case-by-case basis, I don't think that it's both not practical and I think it's not the role of the board.
Yeah, I'd clarify that it is in the statute that the board provides input on a performance improvement plan, and this could happen in closed session, and not everyone is going to go to a performance improvement plan.
Yeah, and I'll just say, I think that these are all obviously really meaty, really valid discussions that are going to have to happen in time and in step. And so I think really as Michelle was saying, what we're trying to focus on today is this assessing performance piece. Like before we can even get to what TA looks like, or what a PIP looks like, or what penalties will be, or who moves where and how, we first need to have this discussion that we're going to try to guide today on. So how do we assess performance? What are the things that we're going to take into consideration? What should we be taking into consideration, and how? I think we have some in-depth discussions that we want to review on high-cost drugs is one example, but really trying to focus today's discussion here. And obviously we know that these are all discussions that have to happen sort of in process and in time.
Thank you. I have maybe even a more basic conversation, which is why are we already undermining enforcement before we've even encountered a challenge? Like, why are we borrowing trouble? I mean, the only one right now that I would support on this list is the acts of God or catastrophic events, because we don't know yet that there are I mean, to Dr. Pan's point, we've already had a pretty big change in federal law. And so does that mean the enforcement's, is not going to happen? I feel like we are really premature in anticipating these problems and basically undercutting the role of OCA. And I'm really nervous about us being in the business of technical assistance. I mean, we're not like management consultants, and there's a lot of them out there that charge a lot of money for this kind of thing. So the whole direction is making me fairly uncomfortable, and I would caution that we move more slowly and in response to challenges, not anticipating them. But that's my take.
Yeah, thank you, Board Member Mitchell. I'd clarify that, we will have a more detailed discussion on what technical assistance means. OCA staff would not be consultants to healthcare entities and telling them how to run their organizations. But we will, have a public discussion about kind of what is technical assistance.
And, I think that this is a huge topic that we're just starting to dive into, and we needed to at least present the components of the statute. And even though Vishal and I both worked on the language, and Dr. Pan worked on the language, and other folks here did, when it's time to implement, you really unpack it in a different way. And so, I think the technical assistance, and again, we'll get more into this, is more about the data. So we are absolutely not going to tell anyone how to run their organization. We are, you all have set a spending target. We are going to hold folks to that. We do need to have a conversation about what the enforcement considerations are. But I think that piece is really more around making sure that they submitted the data correctly and understanding the data pieces. I think, we would look to performance improvement plans being a lot of the same components that we've talked about around primary care, around value-based purchasing and the like. So again, introductory conversation and a lot to unpack here.
Thanks. In a similar vein, I think, fortunately, I think the acts of God and even the state and federal legal changes happen rarely enough that we can have a proper discussion here. And to me, on a case-by-case or a year-by-year basis, I think for a conversation like that, it would be crucially important to have truly third-party, independent analysis of what those impacts would be, because they're bound to be differential across the health system and sectors within it. So if we're going to even contemplate straying off the 3.5% target, then we'd have to have a real forensic understanding of who we might contemplate letting off the hook, and by how much. And for better or worse, it was the wisdom of the legislature to charge us with motivating the healthcare sector to reduce its cost growth curve without interceding in its ability to set prices and the market that it's predicated on. And as long as that's the case, then I think, that target setting, we really need to be very narrow in the exceptions that we create, because it is a very soft touch that we're giving. If a day were to come where the legislature and the governor were to charge us with more intrusive rate setting or what have you, then that would be maybe a very different conversation. But absent that, I do think the exceptions and the latitude should be rare and very surgically used.
Thank you, Board Member Lewis. I did want to, to what you raised and what Board Member Mitchell stated, these considerations wouldn't be automatic. It could be considered, and the healthcare entity would need to submit compelling data and information to us that, had it not been for that factor, we would have made the target. So the kind of the onus or the responsibility would be on them. But open to kind of hearing more.
Not to jump the queue, I'm sorry, but I mean, I can guarantee you there will be high-cost drugs And I can guarantee you that they're going to claim that they're making the investment in primary and preventive care. But I just think it's a really slippery slope to really undo the target.
Piling on would agree completely. I mean, I think that if we think that high cost drugs are the systemic problem, then we should revisit the 3.5% and do that, you know, as we were thinking about what the right target is. We said when we adopted the target, we would look at these every year. You know, similarly, I mean, again, I think the federal law is a reason actually to reduce the target, not to increase it, but I could be wrong. And if there's some reason that HR1 arguably is going to cause cost growth to increase across the board, then maybe we should be revisiting the target. But that, you know, we should be very careful about creating a, you know, or catalyzing the consulting industry to, you know, have a lot of business justifying for every hospital why they're exceeding the target. I mean, I look at the Oregon list, and you know, that way lies madness, I think, to have such a long list, or that way lies, you know, lots of profit for consulting firms.
Yeah, we've heard others say that Oregon, other commentators on Oregon's approach, that it may be too broad, that their list is kind of too many factors.
So I'll be sure we go to slide 80, because that's what the statute says that founded this office. Right. Now, it doesn't say the waiver is a blanket waiver, right? But we need to consider reasonable factors out, specifically changes the state of federal law, dissipate those other factors. It doesn't mean that we give a blanket waiver, oh, well, somebody changed Medicaid law or they changed federal law, that therefore there's a blanket waiver. But I do think that, and again, I agree with you, Dr. Kronik, that the withdrawal of government funds for healthcare will decrease overall healthcare spend, but they'll have different effects on different entities depending on the circumstances of the environment and their, their community and other types of things. And that could have, for one entity, it could actually have an impact that may affect, the cost structure or something. So I think that what we need to do is take account, these factors are in statute, that if they said high cost drugs, okay, well, then how much is high cost drugs? It's not like, oh, well, now there's no cost target and we don't look at anything. We can say, okay, well, if high cost drugs, then how much is high cost drugs? Are you by exactly that amount, or were you more than that? Because that doesn't seem to be accounted by the high cost drug. I mean, we can ask questions like that. So to me, these are factors that the legislature has passed. We need to take account of that, and we can ask for people to explain how that factor, which is in here, influenced their, the finances in a way, and of what magnitude, not just that, oh, it influenced, but of what magnitude, and is what they're asking for is of the similar magnitude or not, in the right in the correct direction. So I think, these are factors I think we need to take account of, and it's up to the entity to explain to us how it led to potentially, I assume this is in the case where you're over the cost target, it led to it, and how that particular factor contributed and at what magnitude, and is that somehow in line with the amount that they're off the target. If it's not, they're like, okay, well, then you still have a problem. So, so I do think these are factors we need to take account of. And if an entity wants to say this is a factor that contributed, then fine, explain the contribution. Explain how it's contributed and how big the contribution it was. And that makes sense for us to say, okay, well, you're going to get a waiver, but if it's only this much and you're asking and you exceeded by that much, well, that might not be good enough.
On slide 80, we would note that this is a May. So I think this is why Vishal was very careful to talk about the reasonable factors being different than the enforcement considerations. So I think he can get us to a similar place to some extent. But again, the waiver component is up to the office to decide. And yes, and I think the language is really important, that it's extraordinary circumstances, suggesting that they should be limited factors.
And I would say at a minimum, if the office does go this direction, that it turns the may into a will, that covered entities should be asked, and this will be hard, but maybe more money for consultants to compare the effects at their institution to statewide. Right? I mean, we've sort of, at least implicitly, if not certainly not explicit, but implicitly in setting the statewide target, we acknowledge that there are all these pressures out here. So simply showing that, the cost of drugs are increasing, it should not be enough, in my view, to justify, exceeding the target, because the cost of drugs are increasing everywhere. And it's only if they're increasing more at one entity than another that would justify exceeding the target. The increasing cost of drugs everywhere might cause us to rethink the 3.5%. As we might say, well, we thought 3.5% was right when we adopted it. Now that we see all these new drugs coming out, actually, we think it should be 4%. But that shouldn't be a kind of entity-specific effect.
Sorry, just to pile on perhaps again, the point is affordability of healthcare. And it's not about how do we give everyone a pass for not creating affordable healthcare. So even though costs are going up, we still have to deal with the impact on the consumer and the purchaser. So I just, again, weigh in very heavily. Keep it at a may, not a shall, and also just really limited, because we don't even know if they're not going to meet the target yet. I understand the skepticism, but I think that's incumbent upon the industry to solve.
Yeah, sort of when I reviewed this slide, my gut sort of said this feels like a slippery slope. And so I think we're always going to have changes in Medi-Cal. There are always going to be changes in regulations. There's always going to be federal rules that are changing. And the industry will have to figure out how to adapt to those as a whole. If we decide the spending target's different, should be different, that's a different issue entirely. But I would have a very short list of things that would be considered, and let's see what people bring. People also, these entities all know that we're trying to expand primary care. People know we're trying to expand behavioral health access. I mean, these are all goals that the industry, I would hope, like us, is interested in doing. And so we have a lot of capability in the statute, and there are all kinds of consultants that will do the things that they will do. And I would be very careful of having a slippery slope of the considerations by which we would let people take a pass.
I think, first of all, I don't think we're talking about giving people just a blanket pass. A couple of other things I just have to note is that, first of all, we established these cost targets before many of the changes that are going to happen in federal and even state law. And as I said before, this is not some minor adjustment that's happening to the Medicaid or even Medicare program. These are probably some of the most significant changes to these programs since the ACA passed. As we heard from the public testimony, right, we're undoing about half of all the Medicaid expansion, right? We're hobbling some of the, at least some of the progress we've made on the in the health exchange. So this is not some like, oh, well, there's a minor adjustment and you're using it as an excuse for a, for a blanket waiver. So let's acknowledge that. The second thing is, yes, the industry does have to adjust, but we based our cost target on median household income. If your drug, especially drug expense, is going up much more than that, then the decision is whether you provide access to it or not at that point. Okay, obviously, we've had our discussion, and so I certainly understand why we picked that, but let's understand that that had no connection with some of these underlying factors. And yes, it is affordability, but we also, in the statute says it's about access too, right? So it's without trying to remove access. So yes, we're going to try to continue. We will continue to put as much downward pressure as we can without undoing, hopefully, the access that people need to healthcare. And unfortunately, we are running against some countercurrents in federal and, unfortunately, because the state has to respond, state law that's also decreasing access. So, part of the challenge is, yes, we're mainly about affordability, but those other factors are also in the statute that we need to consider. And so let's do this in a way that tries to get the best outcome for the people of California. And I know that's what you're all going to do, but I'm a little concerned about this discussion because this is not just, we're not talking about just some minor adjustments to the health programs that we have right now.
If I could, Madam Secretary, to be fair, the lack of affordability has been growing in our industry pre-ACA, when we had the uninsured rate in double digits. So yes, we're going to get a rollback of ACA. Yes, we're going to have more uninsured. Access is going to be reduced. I think we would stipulate to that. That's not because of the affordability and the spending targets. The affordability trends that we've had have been going on for well over pre-ACA days. And so, exactly. So, yes, I completely stipulate, Senator Pan, that this is an enormous change, H.R. 1. And there will be a lot of adaptation that our entire delivery system will need to be able to do. But affordability has been an ongoing issue pre-ACA, and when our uninsured rates were 11 and 12%. I don't have the exact dates. So I don't want to either underestimate the impact of H.R. 1, nor should we underestimate the impact of affordability on consumers. And access is going to be less with H.R. 1 happening. Utilization is going to go down with H.R. happening. And so there are a lot of moving levers in the system, but I would not let H.R. 1 alone allow for our delivery system to take a pass on these spending targets.
Thank you all for that discussion. And again, you can hear also some considerations about how we think about these items, particularly state and federal law, in the overall context of the spending target versus any particular individual. So I think more conversation to be had. What we're going to do is we're going to take public comment on this section of this item. We're going to take it again after we cover the high-cost drugs component as well, but we would love to open it up for public comment for some initial thoughts based on the conversation so far on this item.
All right, let's take public comment. We'll go to the podium.
Thank you for taking public comment at this juncture. I was just trying to figure out how I'd do it after all of the discussion to come. I would ask that we go back to slide 77, which is actually the enforcement considerations, rather than slide 80, which is the possible waiver. The enforcement considerations talk about factors that contribute to spending in excess of the applicable target and the extent to which each entity has control over the applicable components of its cost target. So when we think about that, I'm not sure that high-cost drugs belongs on this list, in part because there is some ability to control the cost of even high-cost drugs. We'll have more discussion about that in the next segment, but for us, looking at enforcement, and this is just the beginning of what is plainly going to be a very long discussion about how to do enforcement, this board has set a meaningful target to improve affordability. We completely agree with Board Member Hernandez that affordability problems date back, well, probably as long as both she and I can remember, and a long time, and that we need to be taking action to bend the cost curve so that we're not continuing to have premiums go up while incomes are flat and while wages are suppressed because of higher healthcare costs and people lack access because they can't afford to pick up their prescription, they can't afford to see the doctor, they can't afford to get a lab test. So we continue to be committed to basing the cost target on median income. We do look forward to a discussion on the cost target in the new environment, which we're obviously acutely aware of. But we want to keep, our law is very different than the Oregon law or the Massachusetts law, and deliberately so. And it is important that we keep focusing on those things which entities have control over. For example, half of hospitals are 340B hospitals and presumably get the lower drug prices as a result. So we'll look forward to continued discussion. Thank you.
Thank you. Looking virtually, seeing a hand raised. Mindy, you should be unmuted on our end. Go ahead. Mindy, you should be unmuted on our end. You'll need to unmute on yours. In the top right-hand corner of the screen, you should see something, a little speaker icon you'll need to click. Go ahead.
My apologies. Good afternoon, everyone. My name is Mindy Maschmeyer, and I'm speaking today on behalf of Montage Health. We conducted a preliminary analysis of the reconciliation bill's impact on our health system, and the findings are deeply concerning. The bill's unprecedented cuts to Medicaid and Medicare payments will reduce our annual revenues by tens of millions of dollars. At the same time, it will significantly increase the burden of uncompensated care we are expected to provide our community. This is not sustainable. California hospitals and healthcare providers are under assault. The financial strain we are facing is not theoretical, it is immediate and real. The Office of Healthcare Affordability must act now. We urge this board to reconsider and reverse its previous actions that compound the damage of these federal policy changes. Instead, we need bold leadership and urgent action to stabilize and strengthen California's healthcare delivery system. This is the new reality. The policies in question are now law. We cannot afford to continue down a path that inflicts further harm on our hospitals already in crisis. We need solutions that reflect the gravity of this moment, solutions that protect access to care, preserve essential services, and ensure the long-term viability of healthcare in our state. Thank you.
Thank you. Looking to the podium. Go ahead.
Hi, Ben Johnson, California Hospital Association. The legislature was intentional and I think clear in asking OCA to promote affordability without negatively affecting access, quality, equity, workforce stability, and other things we want in our healthcare delivery system. And we have asked OCA to balance its efforts on affordability with protections to preserve these other factors like access, setting spending targets that account for drivers like drug costs, but also like federal and state policy changes, be that tariffs, be that HR 1, be that the minimum wage implemented a few years ago, or general economic trends that are more recent than the 20-year look back that was used to develop the spending target. And as well as finally investments that are intended to promote access in communities across California. OCA declined to do so in the setting of the target and instead has provided assurances, I think publicly, to the legislature and others that it will account for drivers like these in the enforcement process through consideration of whether or not and the magnitude of enforcement. And so while we maintain that incorporating drivers on healthcare spending into the targets themselves is really important for promoting certainty and confidence in an already uncertain process and environment, promulgating via regulation a comprehensive set of reasonable factors for growth outside the target is absolutely essential. And ultimately, this is one aspect of a very what's going to be a complicated and diverse enforcement process, and we look forward to engaging on its various attributes. Thank you.
Thank you. Looking virtually, seeing no hands raised and no one at the podium, that concludes public comment on this portion of this agenda item.
Part B.
So in this next section, I want to turn on some work that OCA has already begun to learn more about high-cost drugs. So the reason we had some of these conversations with healthcare entities is that, as you know, as members of the board, you've received letters where the high-cost of drugs has been mentioned. So we really wanted to do a deeper dive in learning more about this topic so that it could inform the board's input on whether this should be considered as a factor. So just to give you a little detail on our approach, we met with 8 stakeholders, including plans, physician organizations, hospitals, and consumer advocates. We primarily focused our discussion on trying to understand the extent of control over drug costs, trends in high-cost drugs, relationships between various entities in the workflow, feedback from entities on, if we were to consider a factor, how would we operationalize it? And then our conversations primarily focused on physician-administered drugs, but we did, discuss retail pharmacy drugs to some extent. On the next slide, I know many of the members of the board are kind of familiar with this distinction, but just want to, for the benefit of the public, give a little background on the distinction. So on this slide, we see the difference between retail drugs and physician-administered drugs. This distinction is important because there are significant price differences for the same drug, depending on whether it's administered in a hospital outpatient department, inpatient department, physician's office, or purchased at a retail pharmacy. So retail drugs are purchased by the patient at a retail pharmacy. They can include oral medications, some injectables like insulin, and other medications that can be self-administered. Physician-administered drugs are usually purchased by the physician's office or hospital and administered to a patient. And they include infusions, injections and medications administered in a clinical or hospital setting. So on the next slide, won't go over everything on this slide, but just to kind of, the pharmaceutical sector has its own set of nuances. So we included some information here. As many of you know, health plans contract with PBMs and they pay for the drugs. And then physician organizations administer physician-administered drugs as well as monitor and manage drug administration and potential drug interactions. Hospitals also obtain drugs from wholesalers or GPOs or group purchasing organizations. They also manage inpatient and outpatient drug administration. And then consumer advocates also have a role to play in terms of advocating for policy changes that make drugs more affordable and accessible. They also support efforts to hold drug companies and healthcare entities accountable. Next slide. So this is a figure from the Drug Channels Institute. It's a visual representation of various entities and their role in pharmaceutical contracts, payments, shipment, and administration. We can see the complexities of the relationship with various levels of contracts, rebates going in multiple directions, and shipments going in multiple directions. Next slide. This is another kind of set of background information to go over the difference between a PBM and a GPO. PBMs emerged in the 1960s to manage prescription drug benefits for insurance companies, handling claims processing and reimbursement. There's a list of several trends that many of you are familiar with. Taking one as an example, PBMs negotiate rebates with pharmaceutical companies, but the impact of these rebates on drug prices and patient costs is a subject of ongoing debate and really trying to shed a light on what the net price is or net cost. For GPOs, they emerged in the early 20th century as a way for hospitals and other healthcare providers to pool their purchasing power to negotiate lower prices from suppliers. They leverage buying power. The leveraged buying power allows smaller entities to access the same discounts as larger organizations. Some current trends that have been observed with GPOs include they've expanded their roles beyond just procurement, incorporating data analytics and logistics, and and digital strategies with the intent of improving supply chain efficiency. GPOs have faced criticism for potentially limiting competition and choice and for the complexity of their operations and financial structures. Next slide. So some of the key observations, this is essentially kind of a summary of the conversations, and then I'll go into more detail what specific healthcare entities noted. So as a whole, healthcare entities all noted limited ability to control drug costs, anti-inflammatory, oncology, ophthalmic, if I'm saying that correctly, diabetes and obesity drugs were identified as high-cost drugs driving spending. New therapies and new uses of existing high-cost drugs were also identified as key drivers of drug costs. But on the other hand, regular introduction of biosimilars and generics help reduce cost growth. Changes in PBMs and contracts are common and can result in changes to prices and formularies. The lack of transparency in pharmaceutical pricing means entities along the supply chain can increase costs and markups. Next slide. So this set of slides is more suggestions or recommendations for OCA. So these include referencing Oregon's model when developing OCA's mitigating factor for high cost drugs, reference data from the Nashby hospital cost tool, like the cost to charge ratio. They suggested looking at charge masters for what's, how drugs are listed as a charge, encounter data, hospital pharmacy reports, high cost drug carve-outs from contracts, and 340B discount information to verify drug costs and trends. Stakeholders also suggested that data is collected on which drugs are highest costs and determine their impact on an entity's cost growth. Other suggestions included evaluating the DOFR, or Division of Financial Responsibility, which occurs in HMO arrangements between a payer and a provider. And lastly, to examine any cost savings from PBMs. So in the next set of slides, I'll go into more detail about specific entities. So going on to health plans, so health plans also reported that they reported that their influence over drug costs is limited and dependent upon contracts with PBMs and group purchasing organizations. Health plans reported the following drug cost drivers and the conditions are listed there. Another driver they noted was increased utilization, new therapies. They discussed some cost mitigation strategies, which include contracting with multiple PBMs, developing creative group purchasing organizations, managing utilization via prior authorizations, presenting cost information to the prescriber and patient before a script is made or a prescription is made. And then going on to the next slide, plans noted that they often carry financial risk for many injectable drugs due to requirements under state law. They referred to this as the Richmond Bill. So under the Richmond Bill, health plans cannot delegate risk for the following injectables unless there's an active negotiation with the capitated provider to assume that risk. So the common injectables are listed on this slide. These negotiations result in varying configurations and financial risk between plans and providers. It could be a full Richmond carve-out where the physician organization is not financially responsible for the list shown here. Some physician organizations could take on partial risk, including for chemotherapy drugs or certain high-cost risk drugs. It really depends. Next slide. So continuing our observations from health plans, they noted the following barriers to managing costs. Changing PBMs for a better price can also lead to changes in formularies, which present some disruption for consumers. Specialty drugs, they noted, have a limited distribution channel through high-cost facilities. one health plan mentioned that they were trying to switch patients to a biosimilar or generic drug, but the manufacturer, directly provided copay cards to patients, which encouraged them to choose a branded drug. And health plans also noted that allowing patient choice for drugs may lead to selection of high-cost brand drugs. And then health plans also commented that hospitals often mark up drugs beyond the wholesale price. Plans noted that Oregon's broad approach to high-cost drugs as a reasonable factors is a good model, and suggested additional consideration of the entry of new high-cost drugs, new uses or updated guidance about the length of course or where they should be administered, increases in demand, cost, or availability. And then going on to physician organizations, they also report that their influence on drug costs is limited and depends on negotiations with health plans for higher reimbursement payments. They reported drug cost drivers include the list shown on the left. They also reported the following cost mitigation strategies, including negotiating with health plans to remove high-cost drugs from their side of the DOFR or Division of Financial Responsibility. They reported utilizing health plan drug protection plans, so it's akin to like a stop loss for in situations where the physician organization has higher cost runs for drugs. They noted, engaging in internal kind of efficiency or cost savings programs, such as changing practice patterns that encourage the use of biosimilars, site of service redirection from higher cost facilities to preferred sites. And then they also mentioned reference pricing, setting a maximum price for a group of similar drugs. I think I just have one more slide or two more slides on physician organizations. In general, physician organizations do not bear financial risk for retail drugs unless they are part of a health system that has risk for some or all retail drugs. In this case, a physician organization that does have risk for retail drugs, they generally try to refer members to a pharmacy that's within their system, or if the member does go to like a CVS or a Walgreens, and the physician org is on the hook for that, they could be on the they essentially get a deduction from their capitation if the member goes to a pharmacy that's outside of the system. For medical benefit drugs, financial risk for physician organizations can vary, as I mentioned earlier, and some have full risk for home infusion medications and inpatient medications. Many high-cost drugs are rolled into hospital claims. For example, outpatient hospital departments. So they're billed under the medical benefit, and these are not easy to identify compared to retail pharmacy claims. One physician organization reported that when there's a material change in drug costs, such as a new entrant in the market, this could allow them to renegotiate their capitation amounts to account for the change. They give the example of the COVID vaccines. Others try to renegotiate financial risk back to the health plan, but it's really between the health plan and the physician org to see kind of what lands on which side of their DOFR. And then last slide on physician organizations. So physician organizations report that a small number of high-cost drugs are responsible for outsized amounts of their cost growth and drug costs, matching trends seen elsewhere. They gave an example of one drug called Keytruda, which has a cost of $200,000 per patient per year. And they've experienced significant increase in usage as it had once, as the number of indications has increased over time. It now has 49 indications. They noted that the usage is among a small portion of members, but it represents an outsized share of total medical drug spend. Physician organizations suggested to OCA that drugs be excluded that have new codes or a new first-line treatment indication on claims, that we exclude a limited number of high-cost drugs with no cost-effective alternative, and that we potentially drill down to a subset of drug codes that could be compared year over year. And then going on to hospitals. So hospitals report that their control over the cost of drugs is limited to what their GPO or PBM is able to negotiate for them, what they are reimbursed for by Medi-Cal and Medicare, and health plan formulary decisions. They share that drug cost drivers include conditions listed here. They also shared that cost mitigation strategies include switching GPOs to get better pricing, but that it's not always easy. Negotiating to exclude high-cost drugs in contracts. Hospitals noted that some high-cost drugs mitigate overall spending. They gave the example of curative medications like sickle cell disease as one example. On the next slide, so this is kind of more detail on some of the other observations from the meetings. So for critical access hospitals that bill by charges, they typically charge 2x the wholesale price of the drug to cover the cost of labor and supplies. Hospitals also noted that kind of the structure of inpatient reimbursement, if it's per diem or capitated on the inpatient side, there's not an incentive to be providing more services or more drugs. So the suggestion was that they're already being as efficient as they can. A hospital noted that they themselves are an employer, so they looked at their self-insured plan and noted significant savings opportunities. They gave an example of just a dozen patients alone switching from Humira to biosimilars could save millions. To achieve these savings on scale, it would require prescriber and patient education and getting the data from their PBM. Other hospitals, there was some discussion about white or brown bagging, and some hospitals discouraged this because they could provide all drug needs through their own pharmacies, and they noted that they have a policy for clear bagging, and this allows them to reduce delays for patients and minimize waste. And then going on to one more slide about hospitals. So hospitals noted that they're able to renegotiate their contracts with GPOs when there's been a material change, such as new high-cost medications. Hospitals noted that treatment for some indications, like cancer, can change from year to year, impacting costs and potentially impacting performance against the targets. The hospitals suggested that OCA make cost adjustments for inflation and expensive and rare therapies, and whether hospitals opened any new services that are impacting drug spending. One hospital also suggested that OCA focus on the misuse of high-cost drugs rather than volume when considering high-cost drugs as a spending factor. And then lastly, hospitals suggested that the impact of high-cost drugs could be used by, or could be measured or monitored by using drug revenue codes from claims to compare high-cost drugs year over year, evaluating evidence of changes in costs from data and reports, looking at encounter data to tease out the medical benefit pharmacy costs that are typically bundled in capitated payments. And then one more stakeholder slide before we get to board discussion. So when we met with consumer advocates, They suggested that OCA look at the NASHP hospital cost tool to reference what Medicare fee-for-service reimburses for drugs and comparing how many times a hospital is charging over Medicare. Advocates noted that markups of drug costs are driving high spending. While some markup is understandable, they remarked on data from the NASHP hospital cost tool that showed often markups of 4 to 5 times Medicare, and that this is unjustified. Markup behavior may be associated with the market power of the entity. Advocates also remarked on the problem of hospitals marking up already excessively high-priced drugs, such as those priced in the millions, and this results in costs that are passed on to consumers and payers. Lastly, advocates said that health plans, especially those with a large national footprint, should have purchasing power to drive down drug costs. And then turning it to the last slide. So I know some of the conversation happened in our last section about whether this should be an enforcement consideration. We did include some sub-bullets here about how we may want to think about this or discuss it, but turning it back over to the chair to facilitate.
Thank you. That was a lot of information. Ian, please.
There's a rudimentary question in here and then an observation. I remember from public testimony a couple months ago about a chemotherapy infusion that was purchased through the 340B program for round numbers, $150 for the entire course. Medicare would have reimbursed $185 or thereabouts. And the negotiated rate that the hospital received for that treatment was over $80,000. And so when we talk about cost, which of those numbers is a cost and for which entity? It would be helpful to refresh my memory about how we think about that analytically. And then kind of the overarching question to me is, while I understand occasionally new drugs, high-cost drugs come out, it is also true that something like half of all drugs go down in cost, in price year over year, and that reduction in cost is rarely passed on to purchasers or consumers. And so why would we look at one side of the equation and not at the other side and approach this as an overall whole and recognize that yes, costs may be driving up by these certain high-cost drugs, but there is ample room for actors in the health system to lower or counterbalance some or all of that by passing on savings.
Thank you. Something that struck me is all of the parties that you spoke to, all of whom are well-resourced with apparently, smart, well-paid executives, don't seem to have any idea how to address the problem or claim they have no control over the problem. So I don't know why we would pay them to manage a problem that they don't understand, but PBMs are literally, their day job is supposed to be managing drug costs. They're saying they can't do it. The health plans say they can't manage the PBMs. They own the PBMs. There are business incentives in here that we are simply ignoring, and every entity that you reference, other than the consumers, have incentives for costs to go up. So I just think that this is a bit of a sort of rabbit hole. If none of these entities know how to manage costs, then maybe the purchasers and government need to have a bigger role in it. I work with Fortune 50 companies all day. They're facing tariffs, wage growth, all the same things, but they manage them. So I guess I'm a little perplexed as to what we are hoping to learn here, because the business practices that happen every day, like we're trying to get biosimilars adopted, there are barriers. We're trying to get GLP-1 medical management programs. PBMs won't let you. There are business practices that are behind these cost increases that unless we really get at those, I'm not sure how much we can do.
Yeah, no, I mean, there's a conundrum. You're right. The PBMs, which, by the way, I think is it 3, essentially have, I forgot what part of the market share. I mean, it's most of it, right? So they dominate, right? So it's an oligopoly of sorts, right? And we have health plans owning the PBMs, huh? Right, owned by the health plans, right? Yeah. And I think one, certainly one big challenge is that someone invents a drug and people want it. And depending on how much existing competition, especially if it's new, right? The choice is either lower your price. I mean, basically, it's like is basically we won't offer it at all. So, I mean, that's the market, right? So the market is to say, well, if you want it, this is the price I'm offering it, and then you say, no, I don't want to pay that much, so I walk away, right? And so the question is, to what degree do you let people walk away and not provide something, right? Now, you're right. There's different things, by the way. Yes, we have other companies managing things, and by the way, prices have gone up, right? That's they raise prices. That's one of the management ways you manage things. I guess the question is, certainly I agree that if we should try to look at not drug by drug, but the whole package, right? So if they're saving money, some are coming off, and there's more competition, biosimilars, and they're going down, and someone's going up. We should look at that, right? So it's not all about up; it's also about what's coming down. But I do think that I think given and there are certain policy decisions our country has made. Don't necessarily agree with all of them, but that basically says that if you make the investment to develop a new drug, you have patent protections and so forth, and you get to set the price for it. And basically, I guess if you want to negotiate down, you might decide that that's the price, and guess what? You either pay it or you don't. Now, I think we should also look at to what degree anyone sort of pads that price, as they say, right? Right. So, okay, well, this is what the manufacturer's actually, selling it for, not necessarily even wholesale, what they're really selling it, to whether it's PBM or whatever else and so forth. But I can also, I think part of the challenge is going to be is that there, and again, we're talking about, and most noted, we're probably talking about a small number, but they're probably both expensive, and also they're used by enough people that it basically is impacting the healthcare spend. And so we have to make a decision to say that, okay, well, you know what, if it goes over a certain amount, you have the option, or you should just go tell people, sorry, we don't provide this one. We're not going to provide this kind of care here in our hospital or whatever medical group or whatever else, because that will put you over the cost entity. And if you can't manage it, then you just don't offer it. I'm not sure the public's going to be too happy about it if that's what we tell people. But I think we have to acknowledge that at some point, there's, we can look at how well they're trying to do this, but at certain point, if whoever's selling the medication isn't going down at a certain point, that's how much you're going to have to pay for it. Now, again, look at how much they might, if they're padding the cost and stuff beyond that, right? And what they're willing to sell, that's one thing. But fundamentally, if we're saying we want people to have access to this medication, and that's the price that's being offered, and there's no reasonable competitors, right, biosimilar or whatever else, then that is what it's going to cost. And then if we, and then the question is, do they just simply say we're not going to make it available?
Thanks. We could spend, I'm sure, days on pointing fingers and under why are drug prices so high and what to be done about it. I noticed one of the constituent groups you didn't talk with is pharma, which a big part of why drug prices are so high. In particular, to your answer to your question, we did, as you noted, discuss this in the last segment as well, just to kind of repeat. My feedback would be extraordinarily sparingly. And certainly, I look at GLP-1s, that would not be a reason for, in my view, for an entity to come in and say we've exceeded the target. I mean, again, collectively, we as a board might say, well, we should be adjusting the target for GLP-1s. I'm sure there'd be opposition to that, and I'm not suggesting that. But that's a sort of pretty broad systemic factor that's probably not going to have hugely different effects at one entity than another. I mean, there'll be differences, of course. Maybe the cell therapy, if there are 2 institutions in the state only that are doing some new cell therapy that costs $5 million each, maybe that's something to look at. But I would be suggesting exceeding kind of caution and using this criteria very, very sparingly.
Yeah, Rick, because earlier you mentioned this isn't going to, drug costs aren't going to hit everyone in the same way or affect everyone in the same way. So is a gene and cell therapy kind of more of a targeted?
Yeah,
okay.
Many drugs will actually have fairly, GLP-1s. I mean, maybe you're going to be different in one, part of the state than another. Certainly health plans will manage them differently, but I don't think we want to say to the plans that are managing them not so well that that's a reason for exceeding the target. I think something like GLP-1 going to be fairly less heterogeneous than maybe cell therapy, which there may only be a couple of institutions doing it.
Yeah, that's kind of in thinking about the gene and cell therapies, they are expensive, but depending on kind of how big of a plan you are, that cost could be distributed across all your members, and it may not lead you to exceeding the target. But at least from what we heard in some of the meetings with plans, or just generally, like more people are using GLP-1, so that's kind of a bigger cost. So I guess how do we kind of think about that?
I would say that something that is broader, like GLP-1s, might be a reason for us to reconsider the targets, but not to have individual plan-by-plan exceptions. And I wasn't thinking of the cell therapy as a reason necessarily for a plan to exceed its target, but more potentially, and even here I'd be cautious for a hospital to say our costs went up and our revenue went up by more than 3.5%. And the reason is we had 15 patients with a $5 million therapy. Maybe something we should be kind of looking at.
Thank you.
You have reference in a couple of places on the NASHP hospital cost tool. Any initial reflections you want to give us about that tool?
We've started to look at it. It's similar to the data that we presented for the commercial to Medicare price ratio. You could do a deeper dive on drug costs and see kind of what is commercial pay to what Medicare pays. And some of the advocates pointed to that as a good kind of gauge on kind of appropriateness of reimbursement.
So something that's one of the things that's hard to get at is like how much the drug actually really costs, right, versus the wholesale price. Does that database help with that?
It will have the Medicare. I believe you could, if it presents the ratio, I'm pretty sure you could figure out what Medicare paid, which is going to be closer to cost. But yeah, but just drug prices in general, it is hard to tease that out. There are databases where you could get the list price. Yeah, but that is something that, in this exercise, whether, a hospital could, or not just a hospital, but a provider entity could bill at a higher price. And then there's some markup for some administration expenses, but then through the data we're getting in the TME or HCI hospital financials, we won't necessarily know what the expense was, so we can't see what the markup is. So there would need to be some type of external reference point, whether it's list prices or some other data source.
Yeah, that's going to get you nothing. I mean, it's in addition to that whole set of problems, there's the rebate problem. List prices are so unmoored to anything that I don't think it's going to produce a meaningful analysis.
One thing that was brought up in the discussions, which we might want to take in consideration, is essentially, especially if you have a new product that, when I say a new class of drug, not a Me Too kind of new drug, but basically a new class where basically the challenge is that it's not been baked into people's negotiations and stuff, right? And so the question is, if you want to make it available, actually, as a pediatrician, challenge is every time someone comes up with a new vaccine that's now recommended. Now, maybe we're not going to have to worry about that for the next 3.5 years, but you've negotiated with your medical group or with the health plan for a capitation rate. It's supposed to include all the recommended vaccines, and suddenly this new vaccine shows up, right? And it's $200, right? And the problem is you're supposed to give it to, let's say, every kid who's a certain age, right? So it's so then that all adds up, right? Because if something you have to give to a lot of people, or something that's really expensive, or combination of both, like some of the anti-obesity drugs, right? That's what starts moving the needle. And so one of the things we might want to consider is that if there is a new product that there's a compelling reason that people should have access to immediately, like an anti-cancer or something, that people want to make available, but that's not, that's people haven't had, it's been in the last year, so people haven't had time to figure out how to bake that in. Now, Millie, you're still at a bit of a mercy of the pharmaceutical company that created it, right? Because they're going to set the price and, whether that's reasonable or not. But then unfortunately, the other option is to say, guess what? If you provide it and you break the cost target, we're going to penalize you. So basically, you're denying people access to that care, to that particular medication. So I think that's the balance part. But that could be an example of something where you could say that, how do we help our various entities basically out of that rock and the hard place about either denying it or saying it's going to be available, but it's going to push you past the cost target, because it's, again, back to factors out of their control, right? I mean, I think that's the fundamental thing we try to put in the legislation, and that's really the question: is to what degree is it true? Is it out of their, it's out of the control, but it creates an access problem if they decide not to provide it.
There's always stuff like that, and I think that if we think that it's really important and material, then we should change the cost target. But doing this on an entity by entity basis, asking the office to deal with every entity that has exceeded the cost target, and making work for every consultant to come in and create the argument, that seems like a kind of counterproductive, a waste of resources, and not very fair.
So I guess if you don't mind me asking the question, then, is because we haven't done it this year, then perhaps every year at a certain point in time, we should ask our staff to present us with a list of things that would fall under that definition, and we should revisit our cost target every year for those items.
I would support that. I can imagine there'll be some divisions among the board, but I think that's a sensible approach.
So I'm thinking I'm probably the division, but I do not support that. But what I would support is actually talking to some of the purchasers who are having success managing drug costs, like jumbo employers who are self-insured and actually pay for this, unlike the health plans. There are strategies that work, and so I do think, rather than just assuming everyone needs a pass because it's so hard to manage, I would look for those positive outliers and learn from their experience.
I guess, we can do both, right? I mean, I certainly do. If a purchaser has an answer to this dilemma, I'd love to hear it too. So yeah.
Great. Thank you for that discussion. We are going to open it up for public comment again on this item, inclusive of this additional discussion on the high-cost drugs.
We will now take public comment. Looking virtually, seeing a hand raised. Anna, you should be unmuted on our end. You'll need to unmute on yours. Go ahead. Anna, I see your hand raised. It looks like you're not unmuted on your end. You might need to click the unmute button in the top right-hand corner of the screen. All right, we will look to the podium and come back. Thank you. Go ahead.
All right. Good afternoon, OCA board members and executive staff. My name is Ben O'Brien. I'm a former biomedical researcher and current policy analyst with California Life Sciences. California Life Sciences represents over 1,300 organizations in the life sciences community, including pharmaceutical, biotechnology, medical technology, and academic research institutions. All of our members are committed to advancing medical innovation and improving health outcomes across California. Our mission is to facilitate a favorable environment for life sciences to continue to flourish and leading California and the nation by delivering innovative solutions to address the most pressing global health needs. We therefore have a vested interest in working with our state's policymakers and agencies to foster an innovative environment that enables this dynamic biotechnology ecosystem to thrive. We thank Deputy Director Pagani for his comments and reporting on the stakeholder feedback to the question of whether high-cost drugs should act as a mitigating factor for exceeding the annual spending growth targets. As noted in his report, there's one more meeting scheduled in late July. As representatives that cover both medical technology as well as pharmaceuticals and biotechnology, CLS would appreciate being a part of that meeting and trying to contribute to that discussion, offering our perspectives on factors as you guys continue to move forward on that policy and work towards enforcement. Specifically, we feel we could provide some data regarding trends on utilization of high-cost drugs and potentially the relationships between the entities and the complex workflow between drug purchase to administration. Again, as we commented during last month's brief on pharmaceuticals and affordability, CLS stands ready to be a go-to resource for the agency to provide the most understanding of the pharmaceutical field and work together to try to address some of the affordability challenges faced by patients. So again, we look forward to continuing discussions and engage with the board. So thank you.
Thank you. Looking back virtually, noting we have about 3 hands raised. We have heard some folks are having technical difficulties. If for some reason the mute, unmute button is grayed out on your screen and you are unable to unmute on your end, please sign off of the meeting and sign back on. We understand that might solve the issue. We'll go back to Anna. Anna, I see you put your hand down. We will go to Ivana.
Okay, can you hear me?
We can, thank you.
Great. This is Ivana Krajinovic with Unite Here Health. I'm really pleased to see you paying attention to drug prices because, I've testified a number of times about a number of drugs. We're always refreshing our data, and I thought I would share a few more examples. We recently found a local oncology practice in Monterey that charges under 150%, well under 150% of Medicare for chemotherapy. And so we are working to move our members with cancer to that practice, which is not easy because it means disrupting, their relationships with their providers and their care. But we don't really have a choice because when we look at charges like, 486% of Medicare for a patient at Salinas Valley, where our spend has been almost 400,000. We're sort of used to numbers in the 400%, but chemo just really seems out of control, where we have not only charges up at 700 and 900%, but we have some at 1,000, 5,000, 6,000. I'm just looking at the file right now. Most of these charges are 4 digits or 5 digits. We have charges at 14,000%. The winner is a charge at 53,231% of Medicare. Some of those drugs at the very high end are lower cost drugs, but still, it just seems like a place where hospitals are making money. We hold the health plan, the networks that we contract with, responsible as well, because when we've inquired about this, and many of these drugs have been off patent for a long time, they simply say that, well, we just look across the board and negotiate. We don't look, sort of service by service or drug by drug or line by line. And we said, well, you should, because some of the stuff hidden in here is extremely expensive. And it also means that these folks with cancer end up hitting their out-of-pocket maxes, within the first couple months of the year. And that's a significant amount of money for patients who often aren't able to work because of their health. So thank you for your attention to this. And I hope you continue to include the attention to high cost drugs, particularly at hospitals on the medical side, in your analysis.
Thank you. Back to the podium.
Beth Capel for Health Access. I want to begin by thanking the staff for all the work they did to pull this information together. It does show what a number of board members talked about, which is substantial markups or padding. Love that phrase. We, in looking at the very high-cost hospitals, found that Doctors Modesto was charging 11 times Medicare for drugs, which seemed rather a lot. And far above the cost of administering the drug and the associated costs. We would say that drugs are a classic example of a system where everyone from the drug manufacturer to the person who administers or takes the drug, except for the consumer, has an incentive to mark up the price and take another cut along the way. And so that is why OCA exists, because there wasn't a place for consumers and purchasers to raise their voice and say, enough, we can't afford this. Health plan, you're merged with a PBM, you're supposed to have better control. Hospital, we've asked you to meet a target. Maybe instead of 11 times Medicare, you could charge twice. So I think this is, in some parlance, a target-rich environment for reducing healthcare costs. And so we think this is an important discussion. We have looked at the Oregon model. We note that many of the entities that exceeded the target did so allegedly because of costs. We would note that Oregon has not done as careful an examination of what is driving the costs as we would hope you would do before furthering it. We would concur with Board Member Kroenig that high-cost drugs should rarely be a reason for exceeding the target. Thank you.
Thank you. Looking virtually, Gilbert, I see your hand raised. Go ahead.
Good afternoon, everyone. Laura here from Biocom, California. And we represent a full spectrum of the biotech industry, including pharmaceutical and medical device companies, including research universities and investors. A key concern, as mentioned by one of the members here, was that the consolidation of PBMs, whose market concentration has grown from 48% to 79% between 2010 and 2022. These insurance industry middlemen often engage in practices like spread pricing and retain drug rebates meant for patients, driving up prescription costs. Just want to thank everyone here, and we just want to continue to be a part of the process and continue to be engaged and work together. That's it. Thank you.
Anna, I see your hand raised now. Go ahead.
Oh, hi. Great. Can you hear me?
We can.
Wonderful. So my name is Anna Malino, Dr. Anna Malino. I am with National Single Payer and the Movement to End Privatization of Medicare. And I too worry that having to come in under the cost targets, that excessive drug costs will result in lower access. And I'm wondering if OCA, tasked with controlling healthcare costs and increasing access, could consider becoming a monopsony, meaning only one buyer in California. Now, the presentation that we heard, every single healthcare entity without exception shared that they feel they have limited ability to control drug costs. And you're absolutely right that most of them have the incentives all wrong. But if they even did have the correct incentives to lower drug costs, they themselves would not be able to do it. Because it really does require just one buyer to be able to lower the costs of drugs. And so I'm just wondering if that's something that OCA could ever consider doing, being the one buyer. It could exert significant control over the market, driving prices down due to their purchasing power. Thank you.
Thank you. Looking virtually, seeing no other hands raised at this time and no one at the podium, that concludes public comment on this item.
Thank you for that conversation, and again for the team's work on that. And I know that's a continued conversation on our list too, so we will continue to dialogue on that front. I think we're going to open it up for general public comment at this time.
Please step to the podium if you'd like to make a comment on anything on today's agenda or otherwise. Looking virtually, seeing no hands raised, and seeing no one at the podium in the room, that concludes the general public comment period.
Okay, seeing nothing else from board members, I want to thank again the team for all of their work on all items, and the board members and the public for joining us this afternoon. We will hope to see many of you again on August 26th at 10 a.m., same place. Thank you all. Meeting adjourned.